Hello friends, good afternoon. Welcome to the last resort revision for the upcoming FMGE exam. I welcome you all. So let's see who has joined in. All right, so we have a couple of people who've already joined in. Hello everybody, Prem Kishore, Mehdi Veti and Dr. VK and the rest of the world who are joining. So we can take a couple of minutes till everybody is joining in. Abdul Rahim and Adil and Hussein. Hello everybody. So I may not take your name because the list is rapidly growing. So good afternoon everybody. And I'm listening, I'm looking at all of your responses also. So I guess the audio and the video, everything is there, right? So good afternoon. So how many questions expected from this session? As many as possible. I have a whole lot, right? At least 30 to 40 questions, covering the length and breadth of your obs and gynae, mainly focusing on the most recent previous year topics, right? So that is going to be there, right? How long this session is going to be? I think at least 3 to 4 hours is going to be the session length, right? Because it will take us that much time to cover the length and breadth of the subject. And in case things are left, we will have another session. So don't you worry about that, okay? All right. Now, what we have, let's just talk about before we start with the questions, right? Let's just talk about the trend of OBG questions that have been, being asked in FMG, right? So most of the times they are from the previous year topics only, right? So you need to see the past year papers and the recall sessions. You can have a look at them. And even in our LRRs, or whether we are going for rapid revision live on the PrepLadder app also, we are focusing on previous year topics, right? So that is going to be the gist. Archit, the session is going to be same as RR live, not exactly, but yes, again the topics remain the same. So whether it was RR live or whether it is this session, it would more or less touch on the same aspects of the course and aspects of the session. But as you're saying, if Archit, I would say if you've thoroughly watched RR live, then you can skip this session and ease out, because RR live on the PrepLadder app was very exhaustive, very lengthy, and it covered in detail all aspects of the of the obs gynae, right? And yes, we will go as deep as you will allow me to be, because it will also depend on your responses, dear mama, right? Now, let's get started. So, there are simpler questions I have placed, keeping in mind the trend of FMG also, but then again, we will go and dig in deeper into the topics as well. So, which of the following is not required in the diagnosis of PCOS, right? So, they're asking you question about the Rotterdam's criteria. Think again, it's not D, not required in the diagnosis, right? The question is based on Rotterdam's criteria, not required in the diagnosis. Menstrual cycle abnormalities can be there, right? So oligomenorrhea can be there, even amenorrhea can be there, irregular cycles of any kind can be there, short cycles, long cycles, all sorts of menstrual cycle abnormalities can be there pertaining to irregularity mainly, right? Hirsutism is definitely there. Right. Now, insulin resistance and ovarian volume. See, insulin resistance is, of course, behind the pathophysiology of PCOS, right? But in clinical practice, we don't determine insulin resistance to make the diagnosis, right? Generally, we don't perform any testing for insulin resistance. So, insulin resistance is not required to make the diagnosis of PCOS as per Rotterdam's criteria, right? So, keep that in mind, right? There can be features of insulin resistance obviously evident in the woman, like for example a feature of insulin resistance would be, yes, acanthosis nigricans, a feature of insulin resistance would be acanthosis nigricans, right? The dark, blackish and brownish velvety pigmentation, which is generally seen, at the nape of the neck. It can be under the breasts also, on the medial aspect of the thigh also. It can be there, in the axilla also. So, various locations one can find acanthosis nigricans. This is a visible feature of underlying insulin resistance. And like you said, hair-on syndrome, right? So, hair-on syndrome is when you find all of these things together. Hair-on syndrome stands for, IR is for insulin resistance, AN is for acanthosis nigricans, and HA is for hyperandrogenism. Hyperandrogenism, right? Now, some of you were confused with ovarian volume more than 10 ml. So, let us quickly recall the Rotterdam's criteria for diagnosis of PCOS, right? So, criteria for diagnosis is Rotterdam's criteria. Remember the name of this criteria. 2 out of 3 are needed to make the diagnosis. So, what are the 3 things? Menstrual cycle abnormalities, right? Clinical and or biochemical evidence of hyperandrogenism. This is very, very important, right? So, hirsutism, if it is there, it's enough, okay, as a qualifying criteria. Supposing hirsutism is not there, but you are checking serum testosterone levels, serum androgen levels, then they can be elevated. So, and or biochemical evidence of androgen excess and ultrasound appearance of polycystic ovaries. So, this is an image. So, image can be a spotter question, all right. Image, remember this, right? Now, when we say polycystic ovaries, please remember that number of follicles, these 2 to 9 mm follicles, 2 to 9 mm follicles are counted. 2 to 9 mm follicles, measuring 2 to 9 mm, they are counted, and the follicular number is important. Okay. So, earlier it used to be more than or equal to 12, right? Now, earlier it used to be originally by Rotterdam's more than or equal to 12. Okay, now latest is more than or equal to 20 follicles. Okay, keep that in mind also. Now, the follicles can be arranged in this necklace pattern also. Follicles can be arranged in the necklace pattern. Follicles can be arranged, that is also called a string of pearls appearance also. But arranged they can be in any ways. But particularly number of follicles is what is most important. Keep that in mind. So, that is what I am pointing out. It is not peripheral cyst. These are not cysts. These are 2 to 9 mm. They are very small follicles which are counted. Okay. So, keep that in mind also. And you can see this image again image based spotter of PCOS. So, you can see bulky ovaries. Okay. So, remember bulky ovaries in the sense that when we say ultrasound appearance of polycystic ovaries, it's either the number of follicles that are counted and or ovarian volume more than 10 ml and or ovarian volume more than 10 ml. That is also going to be a qualifying criteria for ultrasound appearance of polycystic ovaries, right? And either of the ovaries, even one ovary that is polycystic is enough, because either of the ovaries could have polycystic appearance, right? Now, there are other important pointers, right? LH-FSH ratio is not used to make the diagnosis as per Rotterdam's criteria, but if you look at LH-FSH ratio in PCOS patient, it can be disturbed in the sense more than 2:1. Sex hormone binding globulin levels are decreased, and AMH levels, serum AMH levels are also on the higher side, because AMH is coming from these smaller antral and preantral follicles. So, AMH levels are also increased, right? Ovarian volume and ovarian size. Size, obviously, if the size of the ovaries is going to increase, the volume of the ovaries is increasing, right? So, bulk of the ovaries is increased. Obviously, it is more defined in terms of volume, in the sense when the sonologist checks the volume, he will measure it in 3 planes and then come to the conclusion of the volume. So, on ultrasound we will focus on the volume, not particularly the size. Okay. Now, lifestyle modification and weight reduction is encouraged in all patients of PCOS, whether they are trying to conceive, whether they are not trying to conceive. This is the first line management. This is the basis. PCOS. Okay. Now LH-FSH ratio will be more than 2:1. Okay. Now women who are not wanting to conceive and they have irregular cycles, right? Then for them what is prescribed? Yes, women not wanting to conceive and they are having irregular cycles or they are having hirsutism. What are they prescribed? Very good, oral contraceptive pills. Alright, similarly, first line drug for hirsutism in PCOS also. Supposing if a woman is having PCOS and she is having hirsutism, then also oral contraceptive pills is the choice, right? And yes, JB vlog, normal LH-FSH ratio is 1:2, but that is again day 3 of the cycle, day 2 or day 3 of the cycle, day 2 or day 3 of the cycle, right? Now, what is the drug of choice for ovulation induction in women with PCOS? Yes, first line. See, both clomiphene citrate, letrozole are first line drugs, but if you have to pick one, then letrozole is the drug of choice more than clomiphene citrate, but both are first line drugs. Gonadotropins are second line drugs. Second line drugs are gonadotropins, all right. What is the role of metformin? Metformin by itself is not an ovulation induction drug, okay, but metformin is prescribed to PCOS patients for underlying insulin resistance. So if they have features of insulin resistance, then they can be prescribed. So the role of metformin is as an insulin sensitizer. Now, another one more question pertaining to PCOS. Supposing we have hirsutism, and we have given oral contraceptive pills for 6 months, let's say, generally we tie for 6 months, okay, then there is no relief and we want to add another drug. What will we add? Yes. What will we add? Yes, very good, spironolactone. Now, cryoprecipitate, I think you wanted to write cyproterone acetate, I believe, right? I think you wanted to write cyproterone acetate. So, see, any kind of oral contraceptive pills can be effective in PCOS patients, but generally the pills that are containing, drospirenone, or the containing cyproterone acetate, which have anti-androgenic properties. Now, those are the pills that are preferred, okay. So, no relief, yes, spironolactone. But danazole to has androgenic side effects, okay. So, danazole is not, Dr. VK, danazole is, nowhere are we using danazole these days in clinical practice. It has got severe androgenic side effects. Danazole has androgenic side effects. So, we add spironolactone. Okay. Now, also remember, I am mentioning add spironolactone. Add, meaning spironolactone or any other anti-androgenic drugs. Please remember, anti-androgenic drugs, they are to be prescribed with oral contraceptive pills. Please remember this also. This was asked in NEET PG. Please remember this, anti-androgenic drugs are to be prescribed with oral contraceptive pills, okay, because we don't want a woman to conceive or get pregnant while she is on anti-androgenic drugs. These drugs will cross the placenta, reach the fetus, and in case she gets pregnant, okay, so we don't want her getting pregnant while on anti-androgenic drug treatment. In case she gets pregnant, she happens to carry a male fetus, then the sexual development of the male fetus can be affected, okay. So, please keep that in mind, all right, very important. So, these are some of the very important pointers regarding PCOS, all right. Now, let's move on to the next question. A woman is seen with the complaint of foul smelling vaginal discharge. See, they tend to have question on genital infections very often, and this topic should be 100% thorough. Keep that in mind. You should not attempt a question wrong. If they are asking you about genital infections, this is a very important topic, right? Now, see, when you answer very quickly without reading the question correctly, this is what you do. right? Those of you who are saying answer is option number A, please read. Cannot be used. Cannot be used. Yes, the diagnosis is bacterial vaginosis. Yes, the diagnosis is bacterial vaginosis. All right, because you can see the characteristics of the discharge. No foul smelling vaginal discharge, thin milky white discharge, clue cells on wet smear. So diagnosis is bacterial vaginosis. Clear? And the drug of choice is metronidazole. Now, secnidazole, metronidazole, tinidazole, these are the same class of drugs. Okay, so they can be used. All right, dosing will be different. That's all. Right. Clindamycin is also approved. Clindamycin is also a drug which we can use for bacterial vaginosis, but not erythromycin. So the drug that cannot be used is erythromycin. Keep that in mind. All right. And another question pointer that they ask you is bacterial vaginosis in pregnant women. Bacterial vaginosis in pregnant women. The drug of choice is again metronidazole. It is again metronidazole. Preferably we are going to give by the vaginal route. Preferably we are going to give by the vaginal route. And if the diagnosis of bacterial vaginosis is certain, very good. No partner treatment is needed for bacterial vaginosis. Why? Because this is not a sexually transmitted disease. It's not a sexually transmitted infection. Clear? So keep this in mind. So metronidazole by the vaginal route can be creams, it can be pessaries, right? So there are different modalities. Gels can also be there. Now, remember this flowchart. This is a quick recall flowchart. Keep that in mind. All right. Now, Afzal, yes, we can use oral in second trimester, third trimester. Oral can also be prescribed later on. But generally, we prefer by the vaginal route. Okay. Now, women with the complaint of vaginal discharge per speculum and PV examination is a must, right? Now, see here, if the cervix is healthy and discharge is coming from the vagina, you look at the characteristics of the discharge, right? So, milky white discharge, fishy odor, pH more than 4.5, clue cells are seen, whiff test is positive. What is this criteria? These are the images of clue cells, okay? Just for quick recall, these are the images of clue cells. All right. What is this clinical criteria for diagnosis of bacterial vaginosis called as? Very good. Amsel's criteria. This is Amsel's criteria for the clinical diagnosis of bacterial vaginosis. And they also ask sometimes what is the gold standard? What is the gold standard for bacterial vaginosis diagnosis? Right? Then it is Nugent scoring. Then it is Nugent scoring. Okay, then it is Nugent scoring. All right, gold standard. But generally in clinical practice, this gold standard testing like Nugent scoring with gram stain is generally not done. It's most of the times not required also. Okay, but for MCQs, remember this. Now, if there is greenish frothy discharge which is foul smelling, intense itching, urinary symptoms like dysuria can be there, and very important image based question, strawberry cervix, red dots on the cervix, or they can be on the vagina also, strawberry cervix or strawberry vagina, right? Alkaline pH in the vagina and just a wet smear if we do. Right. So, the investigation of choice most of the times for vaginitis is wet smear. Okay. When we have a vaginal discharge, investigation of choice, a simple investigation which can be done is wet smear. So, we can see flagellated microorganism, right? What is this? Very good. This is trichomoniasis, trichomoniasis. And what is the drug of choice for trichomoniasis? The drug of choice for trichomoniasis is also the metronidazole group of drugs. If there is a curdy white discharge with intense itching, very important, pH less than 4.5. Very important, pH less than 4.5. Fungal pseudo-hyphae can be seen on the wet smear or on the KOH smear, right? And what is this? Very good. This is candidiasis. This is candidiasis, and the drug of choice would be the antifungal agents like fluconazole, ketoconazole, miconazole. Any of these can be drugs. Any of these can be used. Generally in clinical practice, fluconazole oral is prescribed, right? Oral fluconazole is generally prescribed. All right. Now, if the discharge is coming out of the os like this, as you can see in the images, if the discharge is coming out of the os or the cervix looks very unhealthy and cervical erosion may be there, then it is clinically cervicitis. Please remember, as long as it is just cervicitis, okay, it is not called as PID, right? The minimum criteria for PID diagnosis, you need to have uterine tenderness, or you need to have adnexal tenderness, or you need to have cervical motion tenderness. Okay, this will be the minimum criteria to diagnose. Okay, minimum criteria to diagnose PID would include, yes, there can be evidence of cervicitis also, but PID means infection of the upper genital tract. Infection has moved up with PID. So, there will be some other symptoms like there can be cervical motion tenderness, or there can be adnexal tenderness, or there can be uterine tenderness. This much is required minimum to make the diagnosis of PID. Keep that in mind, okay? And leukorrhea simply means excessive mucoid vaginal discharge, all right? It simply means that. So, when you have clinically evidence of cervicitis, right, one thing that we can do is take a sample of the discharge and do gram stain of the endocervical smear, or we can do gram stain of the discharge. Okay. Why am I emphasizing on gram stain? Because in the peripheral healthcare centers or in the community healthcare centers, right, generally gram stain is available to us. However, yes, if you look at chlamydia and gonorrhea, these are the two agents of cervicitis, right? Investigation of choice for chlamydia and gonorrhea is nucleic acid amplification tests. Okay, this is the investigation of choice. But this investigation of choice is expensive. It is not available every time in the government healthcare setups. All right. So, even though nucleic acid amplification tests are definitely the investigation of choice, but they may not always be available to us. All right. So, that is why I am focusing on gram stain of endocervical smear. If WBCs are seen and no organisms are seen, presumptive diagnosis is chlamydia. If WBCs are present and gram negative intracellular diplococci is there, then presumptive diagnosis is gonorrhea. So, this is where your microbiology correlates with your gynae, right? Now, see here, for chlamydia, the treatment is doxycycline. This is the preferred regimen. Okay, azithromycin 1 gram single dose can also be used. Now, for gonorrhea, the treatment is ceftriaxone plus doxycycline, and ceftriaxone plus azithro combination can also be used. All right. So, these are broadly the important pointers you need to remember. Okay. Now, if we have kit-based questions. Kit-based questions are also asked. So, please keep in mind, if we have cervical discharge, okay, and we are not able to say whether it is chlamydia, whether it is because of gonorrhea. It is quite possible in peripheral healthcare centers that we are not able to say if it is chlamydia or if it is gonorrhea. Then we treat for both kit 1, azithromycin and cefixime, okay, and we treat the symptomatic partner. If there is vaginal discharge, then and if we cannot say whether it is which kind of vaginal discharge it is, then we treat for all causative agents of vaginal discharge. So, see what does it contain? Secnidazole and fluconazole. So, fluconazole is going to cover for candida, and secnidazole is from the metronidazole group of drugs. It is going to cover for trichomoniasis, and it is going to cover for bacterial vaginosis also, and we treat the symptomatic partner. if there is lower abdominal pain, so if there is PID, lower abdominal pain, then the kit-based treatment is kit 6, which contains cefixime, metro and doxycycline. And if we are treating the woman with kit 6, then we have to treat the partner with kit 1. So these are from the NACO guidelines for syndromic treatment, right? They are important for FMGE also. They are taught to you in Derma also. They are taught to you in PSM also, right? So in variety of places you have read about these kits. Please remember, this can be an important question and it can be repeated, the kit based questions, all right. Also remember, if we have a pregnant woman, with candidiasis, what do we give? Please remember, oral fluconazole is contraindicated in pregnancy. So we give vaginal clotrimazole, okay, this is preferred. Pregnant woman with candidiasis, vaginal clotrimazole, right? Now, if there is a pregnant woman with cervicitis, can you see here? Again, come here. If you can see a woman with cervicitis and she is pregnant also, then what is the treatment? Pregnant woman with cervicitis, what is the treatment? We can give azithromycin, we can give in pregnancy. Ceftriaxone we can give in pregnancy, ceftriaxone we can give, azithro we can give. Please remember, doxy and fluoroquinolones, they are contraindicated in pregnancy. These two drugs you will not give. Okay, doxy and fluoroquinolones are contraindicated in pregnancy. These two you will not give. So this, in pregnant women, doxycycline regimen you will not give, but you can give azithromycin. You can give erythromycin also, right? So ceftriaxone, doxy combination you will not give, but you can give ceftriaxone, azithro combination in pregnant woman. And fluoroquinolones are also contraindicated in pregnant women. So fluoroquinolones are also effective against gonorrhea, but again, they are not the preferred regimens. Okay, keep that in mind. So this, we have covered the important pointers. This is a very high yielding chart. Please remember word by word. This is very, very important, very high yielding. Next question. A 15-year-old girl is brought in by her mother in emergency with acute urinary retention. On abdominal palpation, there is suprapubic bulge. This is an often repeated question. That is why we keep doing it in the sessions. Okay. See, it can be asked in a variety of ways, right? So they could give you a clinical profile and they could ask you what is the diagnosis. They could give you a clinical profile. They could ask you what investigation should you do. They could give you a clinical profile and ask you what is the best treatment for this. Okay. So please remember this. Yes. So lump abdomen is there arising from the pelvis and local exam findings are seen. So you have a bluish bulge at the introitus. Okay. This is imperforate hymen. Very good. All of you know this question. Right. So when you have imperforate hymen, the girl will not have attained menarche. So it will cause primary amenorrhea. It will present with primary amenorrhea. Also remember that the breast development, the entire hormonal profile and everything will all be normal in such patients with imperforate hymen or with outflow tract abnormalities, right? So breast development, hormonal profile will all be normal. So if you have to do any investigation, you at the most will do an ultrasound pelvis. Ultrasound pelvis you can do to begin with. Okay, to begin with you can do an ultrasound pelvis to check for the collection. What collection am I talking about? I am talking about the collection of blood inside the vagina. How is it collecting inside the uterus also? Is it collecting inside the fallopian tube also? So just for that documentation, you can do this. Okay. So investigation, ultrasound pelvis to begin with, right? And it's not a fibroid uterus. What is this lump abdomen? This lump abdomen is again the blood that has collected inside the vagina and the uterus, which is enlarging the uterus and giving rise to an abdominopelvic lump. It is not a transverse vaginal septum. Transverse vaginal septum generally tends to be higher up in location. Okay, generally tends to be higher up in location, and there will be no bluish bulge at the introitus. Just at the vaginal opening, there won't be a bluish bulge. So, it is not transverse vaginal septum. In Mullerian agenesis, the uterus is absent. Right. So, if the uterus is absent, there is no question of hidden menses, because again there is no source of menstruation, isn't it? So, this Mullerian agenesis is also out. All right. Now, again, yes, what is the treatment? Give a cruciate incision over the hymen. Cruciate incision over the hymen is the treatment. No suction evacuation, no removal of contents. Let the content drain on its own. Just give a cruciate incision. Okay. No sucking out the contents, no curating out the contents, no nothing of that sort. Just give a cruciate incision over the hymen. And yes, cruciate is an X-shaped incision like this, right? And very good, you are saying renal anomalies can be there with Mullerian agenesis. And transverse vaginal septum can also be associated with other Mullerian anomalies also. So, when we have transverse vaginal septum as the diagnosis, then there is utility of doing MRI pelvis for evaluating other associated anomalies. For imperforate hymen, it is usually an isolated anomaly, right? Okay. Now, let's have a look at these high yielding flowcharts also. And yes, Tanya, you are right. Hematometra, hematocolpos. This is what we call, when I was talking about the collection inside the vagina or collection inside the uterus. Okay. Now, and the next question, the latest question here, your name is, it's just numbers and alphabets, but you'll get a hang of what these flowcharts are. So, we're going to cover all that, right? So, delayed puberty / primary amenorrhea clinical profile would be absence of menses by 13 years of age in the absence of secondary sexual characters, and by 15 years of age in the presence of secondary sexual characters, right? So, this is going to be the clinical profile. First thing you look at in the question, what they are telling about breast development. See, if breast development is absent, meaning there is estrogen deficiency. If there is estrogen deficiency, problem is with the HPO axis. HPO axis is the problem, not the uterus. Keep that in mind, okay? If breast development is present, that in itself means that estrogen deficiency is not there. Estrogen must be normal. That is why breast development is happening. So, breast development present itself means that estrogen must be produced normally. That means hypothalamus, pituitary, ovary, everything must be fine. So, problem must be with the uterus. Okay. So, what are they telling you? If there is history of cryptomenorrhea. Cryptomenorrhea is hidden menses, like cyclical abdominal pain is happening, but nothing is coming out. Okay, no outflow of menses is happening, and they give you the information uterus is present. How will you know that the uterus is present? Uterus can be felt on per rectal examination, can be felt on per rectal examination, or we do an ultrasound which shows that the uterus is present. Okay, so when you have a situation like this, it is very important that you do a pelvic ultrasound to see if the uterus is present or not. So, if breast development is present, focus on the uterus. Is the uterus present or not? Okay. So, if the uterus is present, bluish bulge at introitus, diagnosis is imperforate hymen, treatment is cruciate incision, I have already told you. If there is no bluish bulge, okay, if there is no bluish bulge, local examination seems normal, then we think about the possibility of transverse vaginal septum. Okay. Now, the other possibility is if the uterus is given to you absent. If the uterus is mentioned as absent, So they can tell you that on ultrasound uterus is absent. Or they may say that there is a blind vaginal pouch. What does a blind vaginal pouch means? That means that there's just a blind vaginal pouch like this. There is no cervix poking inside. If there's no cervix poking inside, most likely the uterus is also absent. Okay, developmentally they come from the Mullerian duct, isn't it? So most likely, so they may give you either of the two informations. Okay, then the possibility is Mullerian agenesis versus complete androgen insensitivity syndrome. Then this information, this chart is going to help you. In Mullerian agenesis, the gonads are ovaries. Serum testosterone is in the normal female range and the karyotype is 46XX. Okay, Tanya, not Turner syndrome. We're going to talk about Turner syndrome in a bit. Now, complete androgen insensitivity syndrome, the gonads are testes. The serum testosterone is elevated in the male range. Okay, and the karyotype is 46XY. So, karyotype becomes confirmatory in making the diagnosis in these situations. Okay, so these are the two possibilities which we consider. Alright, now talking about where you are answering Turner syndrome and where you are talking about what if the breast development is absent. Let's talk about this situation. Okay, now what is the range? See, normal female range is 20 to 80 nanogram per ml. This is the normal female range, and in the male range is just 10 times, 200 to 800. Okay, now let's talk about this. Delayed puberty is there. Okay, primary amenorrhea is there, and absent breast development is there. So we go for a complete hormonal profile. Ideally, we go for a complete hormonal profile. Okay, FSH, LH, estradiol, TSH, prolactin, the entire hormonal profile is done. But if you have to pick one, pick FSH as the answer, because it is FSH which is helping you divide the diagnosis into two parts. Okay? Alright. So, if the FSH is high, then hypergonadotropic hypogonadism is the answer. Okay? If the FSH is high, meaning ovaries are the problem. That is why there is estrogen deficiency, and because of estrogen deficiency, FSH is high. So, if they are mentioning short height, streak ovaries, hypoplastic uterus, then what is your diagnosis, Tanya, here? Short height, streak ovaries, hypoplastic uterus and FSH high. The diagnosis is Turner syndrome. Okay, Turner syndrome. And the karyotype is 45XO. Okay, if she is tall, she has streak gonads and uterus is present, then what is the diagnosis? Yes, tall, streak gonads, uterus is present, and they are not mentioning hypoplastic uterus. Then what is the diagnosis? Other forms of gonadal dysgenesis. Other forms of gonadal dysgenesis can be there. It can be 46XX gonadal dysgenesis. It can be 46XY gonadal dysgenesis, which is also called as Swyer syndrome. Klinefelter syndrome, I don't understand why you keep having this question about Klinefelter syndrome. Klinefelter syndrome is an extra X in a male, okay, 47XXY. Extra X in a male. So, Klinefelters you will see in males, okay, with male infertility, with male hypogonadism. Okay, so that is out, it will not be a part here. Okay, so how will we make the diagnosis? We have to do a karyotype to confirm. Right, because the possibilities are these different types of gonadal dysgenesis. So, how will you identify which type of gonadal dysgenesis? How will you confirm? You will confirm by the karyotype in this situation. Now, you have a situation where the FSH is low, it is called as hypogonadotropic hypogonadism. Right. So, if the FSH is low, problem must be with the pituitary and the hypothalamus. So, if they are mentioning tall woman plus anosmia, she is having, let's say, congenital deficiency of GnRH neurons. What is the diagnosis? Yes, Kallmann syndrome. What is the diagnosis? Kallmann syndrome. Okay. Fine. There can be CNS tumor also. CNS tumor which is, not allowing the pituitary to function properly, not allowing the pituitary production of gonadotropins. Gonadotropins are coming from the anterior pituitary gland. So that can also be responsible. But if there is a CNS tumor, there may be other signs and symptoms of space occupying lesions. For the FMGE level, just remember the CNS tumor is a possible differential diagnosis. And most commonly in this situation is craniopharyngioma. Most common in this situation is craniopharyngioma. Okay. Now, if she is also short, you have ruled out all other causes. Okay. You have ruled out all other causes. So, a diagnosis of exclusion. A diagnosis of exclusion becomes constitutional. Constitutional delay. Okay, a diagnosis of exclusion becomes constitutional delay. Okay, so this is the flow chart for delayed puberty with absent breast development. Okay. Now, so most of the time your questions will revolve around asking you, giving you a clinical profile and asking you the diagnosis. Then focus on the keywords and this flowchart will help you. Now you want to understand Swyer syndrome. See, Swyer syndrome is a type of 46XY gonadal dysgenesis. Okay, so karyotype is 46XY, but so it's an embryological problem, no developmental problem. So despite having 46XY karyotype, the fetus turned out to be female eventually. Why? Because the SRY could be absent. The sex determining region of the Y chromosome is one potential explanation, could be absent. And they are dysgenetic gonads. They are streak gonads. They are dysgenetic. If these gonads in the male fetus are not secreting anything, then how will the male sexual development take place? Because male sexual development needs the fetal testes to secrete androgens in the first place. Isn't it? Got it? Right? So I hope that is clear now. Now, moving on, another important, this has been asked in the past. Turner syndrome is what is most often asked from you people. Please keep in mind, Turner syndrome is most often asked from you people. Karyotype is 45XO. This is the most common karyotype, but there can be mosaic also. There can be Turner mosaic also, like 45XO/46XX, right? There can be mixed gonadal dysgenesis with Turner syndrome also. So Turner mosaic can also be there. And Turner syndrome patients generally have primary amenorrhea, but they can menstruate also. So this is a very typical thing. So when we have 45XO Turner syndrome, right, they will definitely have primary amenorrhea. But sometimes Turner mosaic patients may menstruate. They may menstruate and later have amenorrhea. Okay, so keep this extra bit in mind. All right. Now, the most important finding in case of Turner syndrome, we have this entire head to toe list of the stigmata of Turner syndrome. The most important is short stature. Turner syndrome patients are always short statured. Okay, there is haploinsufficiency of the SHOX gene. So that is why they are always having short stature. Rest all, please see webbed neck and low set ears, shield chest, cubitus valgus, right? Infantile looking external genitalia like a child's, and streak ovaries are there. Hypoplastic uterus is there, I've already mentioned. Intelligence is mostly normal. Apart from this, medical comorbidities can be there like hypothyroidism, so they have to be evaluated for this. Serious anomalies can be there, so they have to be evaluated for this. Renal anomalies can be there, so they have to be evaluated for this. All right, so multidisciplinary approach treatment is needed. Amenorrhea is one part of their problem. They can have other medical comorbidities also. Okay, and osteoporosis. Why osteoporosis? Because they have no source of estrogen in their body, right? So again, they will need long-term hormone replacement therapy, and this hormone replacement therapy will be estrogen followed by estrogen plus progesterone, because they have a uterus. Okay, they have a uterus. So yes, they will need estrogen first. Just like that happens in normal pubertal development, estrogen comes first and then followed by estrogen plus progesterone eventually. They will need this long-term hormone replacement therapy, Turner syndrome patients. Okay, so these are important pointers regarding Turner syndrome that you should keep in mind. Please do not forget that they need to be evaluated for medical comorbidities as well. Okay, now next question. Now this has been asked in your most recent FMGE. Okay, now again, see, the trick to answering these questions is to understand the concepts, right? I don't want you to unnecessarily load yourself with flowcharts. Please remember concepts. How will you solve this question? By eliminating options and looking at keywords. That is what you are going to do. So 37-year-old amenorrhea for 9 months, she is having secondary amenorrhea. Right, there is no withdrawal bleeding on progesterone challenge test and the physical examination is normal. But she reports dryness during sexual intercourse. See, no withdrawal bleeding on progesterone challenge test could mean what? We are giving progesterone from outside, yet there is no withdrawal bleeding happened. Okay, that means either there is estrogen deficiency. There are two possibilities if there is no withdrawal bleeding on progesterone. Okay, please see, I am marking it here. If there is no withdrawal bleeding on progesterone, there are broadly two possibilities. One, either there is estrogen deficiency. Then the reason for estrogen deficiency could be whatever. Okay, so either there is estrogen deficiency because of which endometrium did not proliferate only. So even when we give progesterone from outside, nothing happened. Okay, so either there is estrogen deficiency or the endometrium is problem. Endometrium is scarred. These are the possibilities, right? That endometrium is not responding to anything because there is scarring of the endometrial lining. These are the two possibilities. What does dryness during sexual intercourse suggest to you? It suggests to you estrogen deficiency. Urine pregnancy test is negative. Serum FSH levels are 36. They are on the higher side. Normal female range of serum FSH levels in reproductive age group women is anything between 5 to 20 international units per liter. FSH levels also tend to fluctuate in the cycle also generally, but 36 is on the higher side, definitely on the higher side. More than 40 would be premature menopause, right? Serum AMH is 0.05 nanogram per ml. This is less than 1. AMH is coming from the small antral preantral follicles. If AMH levels are low, meaning low AMH meaning ovarian reserves are falling short, they are decreasing, means follicles are getting depleted. This in turn means follicles are getting depleted. Okay. Now, what is the most likely diagnosis? Is it, so how will you attempt this question? So, all of you have attempted correctly. This is premature ovarian insufficiency because FSH levels is high. That is the same principle I told you here in this chart. FSH high meaning estrogen deficiency must be there. So, premature ovarian insufficiency is the answer. Okay, please remember, low AMH levels are not making the diagnosis. The diagnosis is being made by high FSH levels. PCOS, we have just discussed in the previous question. This is not a PCOS profile. Pituitary failure will have low FSH, deficiency of FSH. Okay, and uterine synechia, if there is Asherman syndrome, then there will be certain history of maybe, curettage, abortion related curettage, postpartum curettage, some curettage history, some event leading to that. Genital tuberculosis is also a common cause of scarring of the endometrial lining. So history clue would be there. And most importantly, if Asherman's is there, then normal FSH and normal estrogen levels would be there. Right? So uterine synechia is not the answer. Right? So how do you answer? By eliminating options and using logic and looking at the keywords. Okay? So premature insufficiency, ovarian insufficiency is the answer. Also remember, when do we call it as premature menopause? When do we call it as premature menopause? When she is less than 40 years. When she is less than 40 years, she is having amenorrhea and FSH is increased more than 40 international units per liter on 2 occasions at least 1 month apart. Then you diagnose premature menopause. Okay, fine. Now, let's have a look at the next question. A 19-year-old girl presented with weight loss, secondary amenorrhea, and a constant fear that she will gain weight. Alteration in which of the following is responsible for this presentation? Yes. Tell me. Constant fear that she will gain weight. So, some psychological history can be there. So, you have situations like you have anorexia nervosa, you have bulimia, you have situations like stress, you have situations like exercise induced, excessive exercise, right? So, what do these situations cause? They cause functional HPO axis suppression. Okay, they cause functional HPO axis suppression. And yes, Insha, high cortisol levels can also contribute. But what is the problem here? They are causing functional HPO axis suppression. So, axis begins from GnRH, right? So, they inhibit GnRH. They inhibit the GnRH secretion. And that's how functional HPO axis suppression happens. So, GnRH, alteration in GnRH is responsible for this presentation. That is your answer. And Tanya, no, who mentioned? Shripad mentioned prolactin. Excellent. Another cause that causes HPO axis suppression is high levels of prolactin. Prolactin also causes menstrual problems. Prolactin also causes menstrual prolactin, hyperprolactinemia, excess prolactin, hyperprolactinemia also inhibits GnRH secretion, So, excess prolactin, hyperprolactinemia can also cause amenorrhea and all other patterns of menstrual cycle irregularity also it can cause. And with prolactin, what else can be there? Galactorrhea can be there. With prolactin, what can also be there? Galactorrhea can be there. Okay. Very good. So, when you have hyperprolactinemia, you are rightly saying antipsychotic drugs could also lead to prolactin excess. So, there are various drugs that lead to hyperprolactinemia, right? I'll just mention here hypothyroidism, drugs, okay. Which kind of drugs? Which kind of drugs? Anybody? Antipsychotic drugs? Yes, but by virtue of what action? Dopamine, antagonist, agonist? Yes, dopamine blockers. So either they are blocking dopamine synthesis inhibitors, either they are causing antagonism or they are blocking dopamine at the receptor level. Whichever ways, but they are antagonizing dopamine. Dopamine inhibiting, dopamine antagonist, those sort of drugs, right? Hypothyroidism can also cause hyperprolactinemia, and yes, prolactinoma. This is prolactin secreting pituitary adenoma. This is prolactin secreting pituitary adenoma. Remember these three important causes for hyperprolactinemia, right? Also keep in mind, which drug will you give? Drug for hyperprolactinemia. If there is hyperprolactinemia, which drugs will bring down prolactin levels? Yes, antagonists are causing excess prolactin levels, agonist. Dopamine agonists are going to be the drug for bringing down the prolactin levels or treating hyperprolactinemia. Very good. So we have bromocriptine, we have cabergoline, right? So generally what is preferred? Cabergoline is generally preferred. Okay, cabergoline is generally preferred over bromocriptine. Cabergoline can be, the dosing is, see, bromocriptine, twice daily dosing is required. Cabergoline twice weekly dosing is required. Lesser side effects. Side effect profile is also better with cabergoline. So cabergoline is generally preferred over bromocriptine. Okay. Yes, Gaurav. If there is a pregnant woman with hyperprolactinemia, pregnant woman with prolactinoma, this you read in surgery or this you read in medicine. If there is a pregnant woman with pituitary adenoma, then bromocriptine is preferable, yes. Okay, and yes, you are saying lactation also. Yes, Tanya. They have asked you this question. I'll just mention it because Tanya mentioned, so we'll just write it here. They have asked this question also. Hormone responsible for lactational amenorrhea? Prolactin. Okay, so that's extra question given by Tanya to us. Now, next question. A 45-year-old multiparous woman with complaint of dysmenorrhea, menorrhagia and chronic pelvic pain undergoes, okay, we're still stuck on the previous question. Afzal, woman want to conceive, treatment can be stopped. Yeah. Yes, woman wants to conceive, treatment can be stopped. In fact, it should be stopped. Okay. But then again, you see here that woman wants to conceive, she will be able to conceive if she starts having regular cycles and she starts having normal prolactin levels. So treatment is continued till normal prolactin levels are achieved and then the treatment can be stopped. Okay. 45-year-old multiparous complaint of dysmenorrhea, menorrhagia and chronic pelvic pain undergoes hysterectomy. From the cut specimen, identify the condition. So with the help of this question, what we will revise? We will revise the difference between adenomyosis versus fibroid, right? So we have to talk about adenomyosis versus fibroid. See, this is not endometriosis. It has a different clinical picture. We'll talk about it in a while. This is not endometrial cancer also. Endometrial cancer will show some growth arising from the endometrium and infiltrating into the myometrium. This isn't it, right? So you can see here that there is thickened myometrium. Okay, there's a bulky uterus, there is thickened myometrium, symmetrically enlarged uterus, excellent, all of you giving the right pointers, right? So generally adenomyosis will have soft, uniformly enlarged uterus. Look at these keywords. Okay, thickened myometrium, right? And what is adenomyosis? Endometrial glands and stroma are buried inside the myometrium. So this is not fibroid, this is adenomyosis, right? Now, if you look at these images, can we identify the images here now? See, this is image on the left. This image is showing a fibroid uterus. Okay, this is a hysterectomy specimen showing a fibroid uterus. Fibroid is a leiomyoma. It is a smooth muscle tumor. It is a smooth muscle tumor, benign, and you can see the characteristic whorled appearance on cut section. Whorled appearance on cut section. Okay, characteristic whorled appearance on cut section. This is intramural fibroid in this image. Intramural is the most common type of fibroid. Intramural, confined to the myometrium. What is this one here? Yes, what is this one here? What is this one here? Identify this image. What is this one here? This is subserosal fibroid. This is subserosal fibroid. This is subserosal fibroid. This is the uterus and this is the subserosal fibroid. This is a laparoscopic myomectomy being performed. Okay. Now, what is this fibroid here? Can you see? Yes, can you see? What is this fibroid? This is the uterus. This is the elongated cervix. It's a huge cervical fibroid. This image here is that of a cervical fibroid. Cervical fibroid. This is called as also dome on St. Paul appearance. Dome on St. Paul appearance. Okay. What about this image? This is the uterus. Okay. Yeah, this is the cervix. And there is a fibroid that is coming out, a huge fibroid that is coming out. Excellent. It is fibroid polyp. Excellent. This is fibroid polyp. Okay. It must be coming out like this from inside the uterus. So, it must have been submucous initially. Okay. It must have been submucous initially. Then it kept growing and protruding. It became intracavitary. Then it kept growing and protruding and it may come out like this. Fibroid polyp. Fibroid polyp. Okay. What is this image here showing you? What is this image showing you here? Last image, image identification. It is a polyp. Yes. Yes. Very good. It is a cervical polyp. So, you can appreciate the difference. This is a very, friable, soft polyp which is arising from the endocervical canal. See, the endocervical lining is columnar, reddish columnar epithelium. So, this is endocervical polyp. This is endocervical polyp. Precisely endocervical polyp, cervical polyp, right? Cervical polyp, which kind? Endocervical polyp. So, keep these important images in mind as well. Now, look at these two ultrasound images. Look at these two ultrasound images. Image on the right showing you what, and image on the left is showing you what. Yes, image on the right is showing you what? Bulky uterus. I'll just highlight and we'll be very quick. Bulky and large uterus. This is the endometrial cavity, and where the endometrium is beginning, where the myometrium is ending, we have no clue, right? So, loss of endomyometrial junction. Thickened posterior wall. See, thickened posterior wall. Loss of endomyometrial junction. Okay. Some cystic areas, let me just highlight. Some black cystic areas. Myometrial cysts, if this is given in the question, right? This is sort of giving a Venetian blind appearance, like the rays of the sun. Venetian blind appearance. Can you see here? As if these are the rays of the sun. The blinds that we see on the windows. The blinds that we see on the windows. So, Venetian blind appearance. So, the second image is that of adenomyosis. Adenomyosis. Okay. Out of these, myometrial cysts is the most specific. Out of these, myometrial cyst is very important. It is most specific for adenomyosis. Also remember, sometimes it is not shown in this image particularly, but salt and pepper appearance of myometrium can also be there. Okay, salt and pepper appearance of myometrium can also be there. I don't have an image for salt and pepper appearance of myometrium. Image on the left. This is the outline of the uterus. This is the uterine cavity, and you can appreciate this. Clearly defined. That is why we saw the gross images first. Clearly defined. This is heterogeneous appearance. Heterogeneous appearance. Well demarcated lesion. This is fibroid. And in this particular case, yes, Priya, and yes, Afzal, in this particular case, this is intramural. In this particular case, it is intramural, yes. Right? Now, ultrasound is most of the times enough to differentiate between fibroid versus adenomyosis. So, if we have a clinical situation where we have suspicion of adenomyosis or we have suspicion of fibroid, right? The initial investigation of choice is ultrasound, pelvis and transvaginal sonography. Most of the times this will be good enough, right? Of course, there can be cases where the diagnosis on ultrasound is not clear and it is confusing. Then we can go for MRI, or maybe MRI is helping us for surgical planning. Then we can go for MRI. So, MRI is not needed all the time. It is an expensive investigation. If required, yes, MRI can also help differentiate between fibroid versus adenomyosis. So, which is which? On the right, we have adenomyosis. On the right, we have adenomyosis. So, you can see here the same, that's why we saw the gross first. Okay, uniformly enlarged uterus, right? Posterior wall is thickened more. These white dots that you are seeing, this white dot here is a myometrial cyst. What other thing you are appreciating is this inner myometrium. What is this? This is junctional zone thickness. What are you seeing on MRI? You are seeing increased junctional zone thickness. More than 12 mm makes the diagnosis of adenomyosis. Less than 8 mm excludes the diagnosis of adenomyosis. 8 to 12 we again equivocal. Okay. Now, image on the left, if you look at it, this is the vagina, this is the vagina and this is the uterine cavity. So distorted. This is one fibroid here, one here, another here. This whole thing is the enlarged uterus, another fibroid here. Multiple fibroids are here in this MRI film. Multiple fibroids are here. In fact, we did an MRI for this woman. Why? Because we were doing a myomectomy for her. I'll give you the context so it will help you remember. MRI is not all the time necessary to make the diagnosis of fibroid, alright. We did MRI in this particular setting because we wanted to clearly find out how many fibroids are there, where exactly are they located, what exactly is their size. We needed all this detailed information because we were planning a myomectomy surgery for her. And that is the reason we did an MRI for this woman. Okay. Now, rest of the images. See here. Image on the left. What are we seeing here? Image on the left and the hysteroscopic conformation. Look at this. This is the outline of the uterus. Okay. And this is the heterogeneous lesion, okay, with vascularity all around the fibroid, all around, right? And this is the hysteroscopic view. This is the submucosal fibroid. This is a submucosal fibroid which is protruding into the uterine cavity, right? So, best for diagnosis of submucosal fibroid is hysteroscopy. Hysteroscopy, best for diagnosis. But it doesn't mean that ultrasound will not be able to diagnose. Even ultrasound can pick up a submucosal fibroid. Obviously, if it is a very small submucosal fibroid and we want to get more detailed anatomy, then best for diagnosis is going to be hysteroscopy. A polyp has to be pedunculated. A polyp has to be pedunculated, then it will be called a polyp. Polyp hangs by a pedicle, my dear, right? Okay. Now, another thing that you will remember here, which is important for MCQs, is that only the submucosal fibroids which are protruding more into the uterine cavity. I'll just draw it out for you so that you remember. So, the fibroids which are submucosal, which are protruding more into the uterine cavity, or they are completely inside the uterine cavity like this. Okay, so this one here is FIGO type 1 and this one here is FIGO type 0. At least remember this. Okay, the fibroids submucosal that are protruding more into the uterine cavity, these are the fibroids that are most likely responsible for heavy menstrual bleeding. These are the fibroids that are most likely contributing to infertility also, and these are the fibroids which have to be dealt with surgery. And what surgery? Hysteroscopic myomectomy. Hysteroscopic myomectomy. Remember this important thing. Okay, so these are the two types of fibroids which are approached hysteroscopically. Okay, surgery is done hysteroscopically. Okay, now what about this image on the right? What about this image on the right? Now, Tanya, while you're figuring out and answering for images on the right, then Tanya and Insha, frequent urination can also be there. Again, fibroids, please remember, they cause symptoms. I keep telling in my lectures, fibroid, the type of symptoms of fibroid causes are by virtue of their location and size. So, if a fibroid is this one here, located here, in the cervix, it can push the urethra in front, it can irritate the bladder in front, so it can cause urinary retention also if it compresses the urethra in front, or it can also cause it can put pressure on the bladder also, and then it can cause frequency of urination also. Okay, fibroids can cause the uterus to become heavy and bulky, then it can cause pressure symptoms also, right? A fibroid that is protruding like this into the vaginal canal can cause postcoital bleeding also, right? So, again, symptoms by virtue of their location. All right, now, did we figure out here? And pregnancy associated complications, infarct, yes, fibroids can contribute to abortions. So again, they have to be submucosal or fibroid polyps or submucosal, then they may contribute to abortion, or they may contribute to infertility, right? So, the submucosal are the ones which creates more symptoms and problems, right? So, you can again understand the location of the fibroid is what is responsible for the type of symptomatology that is going to be there. And in Fan, you are mentioning red degeneration. Red degeneration again can happen in pregnancy. All right. So, this is a polyp, yes, but what kind of polyp? And now we are getting the correct answer. Yes, this is an endometrial polyp. Yes, this is an endometrial polyp, right? So, endometrial polyp, you can see this lesion here is hyperechoic. Hyper, it is appearing whiter. Okay, so there is a hyperechoic lesion inside the uterine cavity, and there is a feeding vessel sign. And there is a feeding vessel sign. Okay, a single feeder vessel, a single feeder vessel. So this is the polyp, no? Endometrial lining, some stroma inside, and the single feeder vessel. Okay, again, best for confirmation is hysteroscopy. This is the hysteroscopy image of a endometrial polyp, soft and friable, arising from the endometrial lining. Definitive confirmation obviously we will have once we remove it. So, hysteroscopic polypectomy will be the treatment in such situations of endometrial polyp. And once we remove the polyp and we send it for histopath, final confirmation will be on histopath. Okay. Now somebody is asking how fibroid can contribute to abortion. Fibroid may not be the only explanation for abortion. Fibroid may not be the only explanation for infertility also. But understand here, if there is this fibroid here and a pregnancy trans to implant over the fibroid, there may be it may fail to implant, implantation failure may occur, so infertility, or a placenta formation is happening over the fibroid and then inadequate placenta formation is happening and then abortion can result. So such sort of complications may happen when the fibroids are associated with pregnancy. Okay. Now, next question, often repeated question. Let's go for the length and breadth of the question in this particular situation. Often repeated in FMGE, often repeated in NEET, INI, CT, everywhere this question is being asked consistently over the past 5 years. Okay. 45-year-old multiparous, obese, hypertensive, heavy menstrual bleeding. Her clinical pelvic exam is normal. Transvaginal sonography shows a small 3 centimeter intramural fibroid. ET is okay, 10 mm. For a 45-year-old reproductive age group, ET 10 mm is fine. What is the next step in her evaluation? I still haven't got the correct answer. See, hysteroscopy is invasive. Okay, it is also going to turn out to be more costly. Right, this is 45-year-old. Age is a risk factor for endometrial hyperplasia and cancer. Obesity is a risk factor. Okay, hypertension by itself is not a risk factor, but it is again age, obesity, hypertensive, right? Diabetes mellitus is a risk factor. So, what are we trying to find? Right? What are we trying to find? We are trying to find an explanation. Okay, there is a small fibroid, but just a 3 centimeter small intramural fibroid will not be responsible for her symptoms. We have to rule out endometrial hyperplasia and cancer. So that's why I say that I will not proceed with hysterectomy. Okay, major surgery hysterectomy. Why? First make the diagnosis and then do a hysterectomy if needed. Hysterectomy should be the last resort. Just because she is multiparous, just because she is 45 doesn't mean that we should remove her uterus. Okay, we should make a diagnosis first. Similarly, I will not proceed with myomectomy. So, before treating, let's have a diagnosis first. Let's rule out endometrial hyperplasia and cancer, and the next step should be an endometrial aspiration, which can be done in the OPD. Okay, and we'll have a histopath of the endometrium, and the histopath will tell us whether it is a normal endometrium, whether it is a hyperplastic endometrium, which kind of endometrial hyperplasia there is, or maybe it picks up cancer or malignancy of the endometrium. Right. So, for now, yes, endometrial aspiration would be the answer. Okay, keep that in mind because it is simple, it will make a diagnosis, it can be done on the OPD basis also. So, that is the initial investigation that we should do. So, please remember what is the indication for performing endometrial aspiration. We are talking about reproductive age group woman with any pattern of abnormal uterine bleeding. When do we go for endometrial aspiration? If her age is more than 40 years, remember this, right? If she has high risk factors for endometrial hyperplasia and endometrial cancer, then we can do it at a earlier age also, or if the endometrial thickness is more than 12 mm, all right, then also we go for endometrial aspiration. Okay, and the other important investigation is that if there is, let's say we started with some medical treatment and failed medical treatment is there, then also we should go for endometrial aspiration. Okay, now why not B? I told you, Saqib, B The reason why it is not B is that it is going to be invasive, it is going to be costly, right? So let us point out what are the indications for performing hysteroscopy, okay? The indications of performing hysteroscopy would be, broadly only we will remember the two most important indications. For example, if there is a clinical suspicion of endometrial pathology, okay? Now, if I am clinically suspecting endometrial polyp, if I am clinically suspecting fibroid polyp, like for example, there is persistent intermenstrual bleeding. Intermenstrual bleeding. Okay, intermenstrual bleeding is a very typical complaint of polyps, endometrial polyps. Or there can be fibroid polyp also. It is a typical problem of some endometrial pathology, persistent intermenstrual bleeding. There has to be a reason why we do a certain investigation, right? So hysteroscopy is when we are going and looking inside the uterine cavity, and at the same time we can perform a polypectomy, at the same time we can go for endometrial sampling. Hysteroscopy guided endometrial sampling can also be done, but it will add to the invasiveness of the procedure. You will have to take the patient to the OT. Obviously, you will have add more cost to the procedure as well. Right. So, clinical suspicion of endometrial pathology, then you perform hysteroscopy, and the other indication would be that she is having persistent symptoms even after a normal endometrial aspiration report. Even after a normal endometrial aspiration report, if she is having persistent symptoms, then we can look inside the uterine cavity. Okay. Clear? Now, why failed medical management? Why failed medical management? Why failed medical management? Because there is a possibility that structural lesions like polyps, small polyps, can be missed, okay, and they may not respond to medical treatment. So, that is why failed medical management. Before we go for basically failed medical management, in the sense that there is always a possibility of endometrial hyperplasia, cancer and polyps when there is failed medical management. So, we should evaluate completely, okay, before going for a definitive therapy. That is the important thing to note. Okay. All right. And if she is pregnant, then the whole question or scenario of abnormal uterine bleeding evaluation would not come. Okay. The whole situation of endometrial evaluation will not come if she is pregnant. Okay. Fine. Now, also tell me what is this instrument? Also tell me what is this instrument? Yes, you can see here what is being performed and what is the instrument. This is endometrial aspiration being done, and this is not a Carmen cannula, this is not a uterine sound. That is why I have given these two images together. It's a very thin plastic cannula. This is Pipel's cannula. This is not Carmen's cannula, this is Pipel's cannula. Uterine sound is going to be a metallic instrument, okay. Here, this device goes inside a plastic sleeve. This is a plastic sleeve. This has one hole. This is an endometrial aspiration cannula, which is Pipel's cannula. This is Cusco's speculum. This is Cusco's speculum. Okay, this is Cusco's speculum. All right. So, this is an OPD based procedure which can be done. Okay. Fine. Now, what is the treatment of choice for endometrial hyperplasia with atypia? Yes. With atypia. It can be simple, it can be complex, doesn't matter. But if there is atypical endometrial hyperplasia, it's a simple hysterectomy. It's a simple hysterectomy. There is high risk of progression to endometrial malignancy. Most of these women will be having completed their family and multiparous, right? So the treatment is simple hysterectomy. What is the treatment of choice for endometrial hyperplasia without atypia? Yes, without atypia. Endometrial hyperplasia without atypia. What is the treatment of choice? Now we go for progesterone therapy. Not estrogen plus progesterone, not oral contraceptive pills, progesterone therapy. Hyperplasia needs to be treated, okay, and preferably Mirena. Not hormone replacement therapy, it's progesterone therapy. It's not estrogen therapy, it's not estrogen plus progesterone therapy, it is not oral contraceptive pills, it is progesterone therapy, preferably Mirena. And tamoxifen is a risk factor for endometrial hyperplasia and cancer. Tamoxifen is a risk factor for endometrial hyperplasia and cancer. Okay, so it's not for treatment. Next question. A 60-year-old woman presents with postmenopausal bleeding. Okay, on per speculum examination, cervix is atrophic looking. Histopath from endometrial sampling show atrophic endometrium. For the past 3 months, bleeding episodes have become more frequent. What should be done next? I have just discussed the concept regarding evaluating the endometrium. Now, please answer this question correctly. What should be done next? We have already done an endometrial sampling. It is showing fragments of atrophic endometrium. Obviously, she is postmenopausal also, but the bleeding has been going on for a long time now. So, now what do we do? Yes, we go for a hysteroscopic examination. Now we go for a hysteroscopic examination and guided biopsy. Okay, guided biopsy. Now we can look at the endometrial lining and maybe do hysteroscopic guided curettage or hysteroscopic guided biopsy of specific areas of the endometrial lining. So, hysteroscopic guided biopsy. Performing hysterectomy will not be right. Why? Because in case it is cancer, then she will need to be operated by a gynae-onco-surgeon. The cancer workup has to be done. So why will I go for a hysterectomy straight away? Then she will need a cancer surgery, a staging, laparotomy and everything, right? Cancer management will be needed. Further workup will be needed. Otherwise, I do a hysterectomy and then, it's incomplete treatment. MRI pelvis will be needed for evaluation of endometrial cancer staging and everything. For that MRI pelvis will be needed. And serum CA125 levels, they can be elevated in endometrial cancer also, but they are not going to make a diagnosis of endometrial cancer. Right? Now, Adil, why is A option better than MRI pelvis? MRI pelvis, what do you want to look at? MRI pelvis, what do you want to look at? What will MRI pelvis show you? If there is a growth, if that growth arising from the endometrium, if it is penetrating into the endometrial lining and cavity and everything. But the point is that whether that growth is cancer or not, you will diagnose by having a histopath diagnosis. Endometrial cancer, endometrial hyperplasias, their histopath diagnosis. So, priority is in making the diagnosis first. So, for making the diagnosis first, preference is given to hysteroscopic examination and guided biopsy, isn't it? So, that is why that should be done next. Also remember, most common cause of postmenopausal bleeding in Indian women is cancer cervix. That is why we have to focus on the cervix also. Here the cervix is atrophic looking. So first we go for a per speculum examination. If there is a growth on the cervix, then punch biopsy of the growth will be done. If there is no growth on cervix, then we focus on the endometrium and the uterus. Then we focus on the endometrium and the uterus. So, initial investigation, a transvaginal sonography. Okay, initial investigation, a transvaginal sonography. We're talking about postmenopausal bleeding. On TVS, if the endometrial thickness is more than or equal to 4 mm, we go for endometrial aspiration. If the endometrial thickness is less than 4 mm, we can observe, but if she has persistent symptoms, then we go for endometrial aspiration. Endometrial aspiration will make the diagnosis. If it is normal but persistent symptoms, we go for hysteroscopy guided endometrial sampling. Okay, fine. So, they ask you this question, what is the investigation of choice for postmenopausal bleeding? Okay, what is the investigation of choice for postmenopausal bleeding? As far as uterine causes are concerned, see, please remember, most common cause of postmenopausal bleeding in Indian women is CS cervix. Worldwide it is atrophic endometritis. Worldwide it is atrophic endometritis. Okay, so hormonal testing and everything is not important here, bache. Hormonal testing postmenopausal. What hormone you will test? You have the deficiency of estrogen. What hormonal test? Diagnosis of priority is to rule out cancer. So investigation of choice for postmenopausal bleeding is endometrial aspiration, endometrial sampling, because priority is in ruling out cancer. Okay, please remember the cutoff for endometrial aspiration in postmenopausal bleeding is 4 mm. Okay, endometrial thickness more than or equal to 4 mm in postmenopausal women who come with postmenopausal bleeding is not okay. Alright. Now, next question. A woman presents with postcoital bleeding on pars speculum examination. The cervix appears congested. While taking a pap sample, cervix starts to bleed on touch. What could be the most probable organism to cause these changes? See, postcoital bleeding is a very specific complaint for some local lesion on the cervix. Okay, now this local lesion on the cervix could be a cervical polyp. It could be a polyp that is coming out of the endometrial lining and coming out and protruding into the vagina. So, it could be a cervical polyp, or it could be cervicitis, or it could be CIN, or it could be cervical cancer. It's a contact bleeding, postcoital bleeding, right? So, it is pointing towards a very specific kind of differential diagnosis where we are suspecting maybe some local lesion on the cervix. So, whenever there is postcoital bleeding, please first of all do a pars speculum examination. If there is a growth on the cervix, we go for a punch biopsy from the growth. If there is no growth on the cervix, please take some form of cervical cancer screening. Okay, please take some form of cervical cancer screening, which can be a pap smear, like we are taking a pap smear here, or it can be HPV DNA testing. Whatever cervical cancer screening method is available, that should be done. And according to the results, the next step is colposcopy. Okay, so here answer is HPV, because again, like I told you, that it's a very specific pointer towards the possibility of cervical intraepithelial neoplasia or towards the possibility of cervical cancer. So priority is in evaluating the cervix. Because the priority is in evaluating the cervix, even if no growth is seen, she is having symptoms. Postcoital bleeding is a very specific complaint pointing towards cervical cancer and possibility of CI, and I'm repeating it n number of times to help you understand that this is a symptomatic patient. So even if there is no growth, even if the cervical cancer screening results come back as negative, screening should definitely be done, but even if the screening tests come back as negative, evaluation by colposcopy is a must. Okay, looking at the cervix under magnification is a must. So keep that in mind. Okay, now since we're talking about cervical cancer screening, let's have a look at the next question. What is co-testing in cervical cancer screening strategy? What is co-testing? Co-testing meaning doing two tests together. Which two tests together? Yes, which two tests together? Yes, very good. No, not HPV and VIA. Co-testing refers to HPV DNA testing plus cytology done at the same sitting or at the same time for screening purposes. But also remember that when we are doing two tests together, it will make the entire package of the test more expensive. Alright, so it is not always necessary to go for co-testing. What is the WHO saying? The WHO guidelines for cervical cancer screening is that screening should begin at the age of 30 years, okay, and by primary HPV DNA testing. Primary HPV DNA testing, this is the preferred thing. Cytology alone can be done, VIA can also be done. In fact, WHO is saying that even in low resource setting, HPV DNA testing should be done, and low cost HPV DNA testing kits should be made available by the countries. This is what WHO guidelines is saying. But for us, yes, in our peripheral healthcare centers, in our villages, we have VIA. We have visual inspection with acetic acid. Please remember this also. But yes, WHO is saying that HPV DNA testing should also be made available in low resource settings also. WHO is saying in low resource setting this should also be made available. With us for now, HPV DNA testing kits are not available by the government in the peripheral healthcare supply. We have VIA, visual inspection with acetic acid. Okay, and when HPV DNA testing is done, it should be repeated every 5 to 10 years is what the WHO is saying, right? And yes, we tend to repeat it every 5 years. If co-testing is also done, then also repeated 5 yearly. If cytology alone is done, it is to be repeated every 3 yearly. If VIA alone is done, then it is to be repeated every 3 yearly. Cytology alone every 3 year, VIA alone every 3 year. These are also acceptable according to WHO. Okay? All right. And HPV screening is to stop with hysterectomy. Yes, if the hysterectomy has been done for benign reasons. Okay. If the hysterectomy has been done for benign reasons, like for example, if the hysterectomy was done for cervical cancer or if the hysterectomy was done for CIN, then the screening continues. Otherwise, the screening can be stopped. Okay. Alright, and yes, Huzef, you are rightly saying it is ACOG which highlights the importance of co-testing. Now, as far as your FMGE exams are concerned, please also identify these devices. What are we seeing here? This wooden, this can also be plastic. This spatula is what is called as the Ayers spatula. It is used for taking the cytology specimen. Okay, this is the cyto brush. This is the cyto brush. Okay, so nowadays we have to take two samples, one from the ectocervix and one from the endocervix also. All right, so so we have to take samples from these two areas when we are taking a cytology sample. Okay, and this is the liquid based cytology. This is the liquid based cytology kit. Okay, right. So with a conventional pap smear, where we are making the slide and dipping the slide in the fixative, The fixative is 90%, 95% ethanol is the fixative. This question is asked from your FMGE exams, all right. And this liquid-based cytology kit, the fixative is methanol. Methanol is the fixative with liquid-based cytology. Okay, in liquid-based cytology, we use this brush to take the sample from the endocervix as well as to take sample from the ectocervical region, and the brush is, dipped in the kit in the fixative, and brush is moved like this, and then, it is centrifuged in the lab, and the slides are prepared in the lab and analyzed. So this is the difference between conventional and liquid-based cytology. Okay, the advantage of liquid-based cytology is that the same sample with the liquid-based cytology, the same sample can be used for cytology plus HPV DNA testing. Plus HPV DNA testing. That is the advantage with the liquid-based cytology. Okay. Now, image. Okay, this is for the holding, and this is the end. Bache, this is the end that will, the spatula, this is the end that will go. The spatula-like end will go and scrape off the area on the ectocervix. Okay. Now, what is this image showing you? Can you identify this particular image? This is visual inspection with acetic acid. 5% acetic acid is used, not undiluted. 5% acetic acid is used, and we can see an abnormal area. Abnormal area will turn white. Abnormal area will turn white. Okay, so it can identify the area. We'll have a visible area. We can biopsy it in the same setting. We can also go for see and treat approach also with the help of VIA. This image here is showing colposcopy. This image here is showing colposcopy. Colposcopy is done for visualizing the cervix under magnification. You see this same patient, this same patient, we are visualizing this area under magnification. We can see the abnormal vessels, we can see the white area in detail. So the utility of colposcopy is, what is the utility of colposcopy? We can go for a guided biopsy, colposcopic guided biopsy done if the screening results are positive. If screening results are positive, then colposcopic guided biopsy can be done. Okay, and VIA in Irfan, abnormal area turns white and the normal area on the ectocervix is bright pink. Abnormal area turns white. Abnormal area turns white. White patch. Okay. All right. Let's have a look at the next question. 18-year-old girl presents with an abdominopelvic lump which on ultrasound evaluation is found to have a solid cystic ovarian mass. So, she is a young girl, solid cystic ovarian mass. Okay, before that Prem Kishore said transformation zone. Yes, transformation zone is this zone. This is, since you are mentioning, this is the scomocolumnar junction, and this area outside the scomocolumnar junction on the ectocervix, this entire area is the transformation zone. Okay. So, the transformation zone is the most common site for CIN and cervical cancer. So, transformation zone should be seen. Completely, transformation zone should be evaluated completely. But again, Irfan, you are rightly saying that from transformation zone it will be squamous cell cancer, but for adenocarcinoma we need sample from the endocervix also. You are right. That is why when we are screening we are taking endocervical sample also. Okay. Now, coming back to this question. 18-year-old girl presents with a lump abdomen. It's a solid cystic ovarian mass, 10 centimeter in size, raised blood flow inside the mass on Doppler. What is the most appropriate next step? Okay, so some of you are saying option A and option B. See, we know that there is suspicion of malignancy. There is suspicion of malignancy, yes. Why is there suspicion of malignancy? Young age, okay. So, extremes of age, right? Plus solid cystic ovarian mass. It's not a simple cyst, there are solid areas, right? Bilaterality also points towards the possibility of malignancy. Raised blood flow inside the mass, so cancer has got neovascularization. Also, multiple septations can be there. Papillary excrescences. So, they can be mentioned in the question. These can be seen on ultrasound also, right? So, suspicion of malignancy is there. So, before, definitely we have to operate. We have to remove this mass, because the confirmation whether a particular ovarian mass is malignant or not will come when the mass is removed, right? But when the possibility of malignancy is there, before planning a surgery, it is very important that we do the tumor markers, so that we have a baseline tumor marker level with us, because these tumor marker levels later on will be followed up after the cancer surgery is done. I also need the tumor markers because I want that the gynae onco surgeon should do this surgery in case of a malignant ovarian mass and after proper workup and evaluation. So, I will not go for a diagnostic laparoscopy. I will not go for an ultrasound guided FNAC also. Ultrasound guided FNAC is not generally needed in case of ovarian masses, because again, in case it is malignant, poking with the needle, can lead to dissemination of malignancy. So, ultrasound guided FNAC is also not a preferable approach, but for now I want to go for tumor markers, and among the option number A and B, it is better to go with option number B, the set of tumor markers here, because LDH is a tumor marker for dysgerminoma. AFP is a tumor marker for endodermal sinus tumor. And HCG is a marker for choriocarcinoma of the ovaries. Okay, and CA125 is a marker for epithelial ovarian. Epithelial ovarian is less likely a possibility in a 18-year-old girl, because the most common type here would be germ cell cancers, and that too dysgerminoma would be the most common, right? So keeping the possibility in mind, it is better to go for option number B as the answer, right? CEA is a marker for mucinous histology. Mucinous histology, and it is epithelial ovarian in type, and epithelial ovarian becomes more likely a possibility, mucinous becomes more likely a possibility in older women. So, considering that she is a young girl, the set of tumor markers to be done would be option number B. That is going to be your answer. All right. Now, also please remember, what are the indications? These are questions that are asked. What are the indications of surgery in an ovarian mass in reproductive age group? See, if it is a simple cyst, unilocular, clear fluid, right? Simple cyst, unilocular, fluid filled cyst is most commonly a follicular cyst. Okay, and these follicular cysts, they keep forming in the ovaries in reproductive age group. They are very common. So, unnecessarily we should not operate. But if the size is more than or equal to 8 centimeter, then we should operate. If the ultrasound features are suggestive of malignancy, then definitely we should operate. Okay, and if there is acute abdomen or torsion, then also we should operate, irrespective of the size, irrespective of the size. Okay. Also remember that there can be a possibility that there is a pregnant woman, she is having ovarian mass or an ovarian cyst. Then the indications to operate are the same. It is only a question of timing. So, timing is between 14 to 16 weeks, not in first trimester, not in first trimester. Okay, but in case there is torsion, ovarian torsion in pregnancy, torsion is a surgical emergency. Okay, and they've asked you this question in FMGE. They asked this question: investigation of choice for ovarian torsion. It is transvaginal sonography, Doppler, ultrasound Doppler, to see the blood flows to the ovary. When the ovary undergoes torsion, what happens? The blood supply to the ovary is compromised. No, so blood flows to the ovaries will have to be checked. So ovarian torsion, if there is torsion, it is an acute surgical emergency. Then it has to be operated. Please remember, operated irrespective of whatever is the size or whatever is the period of gestation. It doesn't matter. It's a surgical emergency, because the ovarian torsion can ultimately lead to ovarian necrosis also, and the necrosis happening inside the abdomen, patient can land up in sepsis, and it can become a life-threatening situation, not just sacrificing the ovaries but also becoming a life-threatening situation. Also remember that in postmenopausal women, ovarian mass, high possibility of cancer. Only and only if she is asymptomatic, unilateral, simple cyst, size less than 5 centimeter and normal CA 125 levels. Only if all of these are there in postmenopausal, then only patient can be observed. If anything is abnormal, we have to operate. If anything is abnormal, we have to operate. Keep that in mind. Alright. So, these are some important pointers regarding your adnexal mass and their management. When I say adnexal mass, meaning a mass that is arising from adnexa. Adnexa means it could arise from the ovary, it could arise from the fallopian tube. In your questions, most of the times they are going to give you ovarian masses. Alright. Now, let's have a look at this ovarian mass. See, the most common ovarian tumor in reproductive age group women, in young women, is a germ cell tumor. That too benign. Which germ cell tumor? Dermoid cyst. What is dermoid cyst? It is a mature cystic teratoma. What is dermoid cyst? It is a mature cystic teratoma. Okay, so you read more about this in pathology, but for now you should remember these images. Okay, you should remember these images, very important. This is the gross image. Can you see? This is dermoid cyst. This is a solid area inside the cyst, right? This is the cyst wall. Cyst inside is filled with sebaceous cheesy material, hair also. Tissues arising from all the 3 germ cell layers, right? And this is the Rokitansky protuberance. Rokitansky protuberance, the solid area from which all these maybe teeth are there, maybe cartilage is there. So, that solid protuberance is called as Rokitansky protuberance. Now, analyze the gross with the images here. Can you see here? This is the cyst. This is the solid area Rokitansky protuberance, right? And we are seeing as if there are white dashes and dots. This is because of the hair inside. This is the dash and dot appearance. Very characteristic of dermoid cyst. Okay, very classic of dermoid cyst. Look at this image here. In this you have an ovarian mass, okay? You have this solid nodule which is Rokitansky protuberance, and everything behind is hidden. This is acoustic shadowing. Everything behind is hidden. Okay, so let's like the tip of the iceberg. It is the tip of the iceberg sign. Tip of the iceberg sign. Okay, as you can see in the image here. So this is very typical of dermoid cyst. Important pointers to note for your exam. I already told you this is the most common ovarian tumor in 2nd and 3rd decades of life. It is also the most common tumor that is identified during pregnancy, because most pregnancies happen in the reproductive young women only. It is bilateral in up to 10 to 15% cases. It is also the most common ovarian tumor to undergo torsion. The lining of the cyst is squamous epithelium, stratified squamous epithelium. If malignant change happen, first of all, it is very, very rare. It is very, very rare. Then it can lead to squamous cell cancer. Okay, so malignant change very, very rare. If malignant change happens, it changes to squamous cell cancer. What is the treatment? It by themselves, it is not malignant, it is benign. So it is cystectomy. It is cystectomy. Treatment is cystectomy, and wherever possible, it is preferably laparoscopic. Minimally invasive, preferably laparoscopic, minimally invasive. So remember these important pointers regarding dermoid cyst. Dermoid cyst is also an often repeated question in your FMG. Now let's have a look at the next question. Which of the following is not a correct timing for copper T insertion? Not a correct timing, not a correct timing. Yes, not a correct timing. Copper T can be introduced postpartum, yes. Can be introduced immediate postpartum. Up to 48 postpartum, yes. So postpartum means post-placental. It can be introduced post-placental, that is within 10 minutes of placental delivery. See, Government of India is promoting copper T insertion. Please remember this, okay? So, one opportunity of going for copper T insertion, obviously after counseling the woman and taking her consent, is when she is on the delivery table, they are more responsible, they are more, likely to accept the method. So, post-placental, within 10 minutes of placental delivery, this opportunity can be used. If this opportunity is not used, then the next opportunity comes in the ward before discharging her from the hospital. So, up to 48 hours postpartum, yes, it can be introduced. Okay. If we have not introduced within 48 hours postpartum, if not, then we cannot introduce it later. Okay. If this opportunity is gone, then after 4 to 6 weeks postpartum. Then after 4 to 6 weeks postpartum. Okay, and yes, for interval copper T incision, it can be inserted within 5 to 7 days from LMP. So, LMPI, right, and then within 5 to 7 days, next 5 to 7 days, it can be introduced, right. Please keep that in mind, right. Important thing is that it should not be introduced right before the periods, not right before the periods, right, because we are introducing inside the uterine cavity. There should not be a pregnancy inside, or there should not be a pregnancy traveling inside, right. So, within 5 to 7 days LMP, yes, we can do that. This is called as interval insertion. Okay, we can go for copper T insertion after abortion also. Post-abortal insertion can also be done. Copper T insertion can be done after vaginal delivery or after cesarean section, like during cesarean section, it doesn't matter. Okay, but postpartum and post-placental, that is what is important. Mode of delivery doesn't matter. Okay, keep that in mind, but not before menses, not premenstrually. So, answer is D. Right. Now, moving on, let's have a look at the next question. A 28-year-old woman, para 1 live 1, is seen in gynae OPD. She is requesting for emergency contraception after 5 days of unprotected intercourse. Emergency contraception is a very, very important topic, right? LMP was 3 weeks ago. What should be the most preferred method? Yes, what should be the most preferred method? Excellent. It is IUCD copper T. Please remember that Mirena is not emergency contraceptive. First of all, remember Mirena is not emergency contraceptive, right? LNG pill, that is the I pill, okay, that is the most commonly used. It is available over the counter. It is available over the counter. ASAP, it should be taken. Okay, so after unprotected intercourse, as soon as preferably within 72 hours, right? Dose you have to know points, dose you have to know. Currently it is 1.5 milligram single tablet, 1.5 milligram single tablet. Okay, another hormonal method is ulipristal acetate. They have asked to this question. Another method is ulipristal acetate, comes under the name ELA, 30 milligram dose, single tablet within 120 hours, 5 days. It can be taken within 120 hours. Also remember that these are hormonal methods. OCP is a hormonal method, misoprostol is a hormonal method, ulipristal acetate hormonal method, LNG pill hormonal method. Please remember that these hormonal methods of emergency contraception, their main mechanism of action is by delaying ovulation. Okay, they delay ovulation. So, for a woman in which ovulation may have already occurred, these methods will not be effective, right? So, that is why here, after 5 days, LMP was 3 weeks ago. Hormonal methods are not okay for this woman. For this woman, IUCD would be the most preferred method. IUCD mechanism of action is IUCD, copper T. The main mechanism of action is inhibition of fertilization more than inhibition of implantation. Copper ions get released, they inhibit fertilization. Okay, so they start to act immediately, right? They are not working, copper T is not working by delaying or inhibiting ovulation. Right? So, this can be effective. In fact, if they ask you blanket question, most effective emergency contraceptive, blanket question if they ask you, answer is copper T. Okay. Now, D, misoprostol has been tried, and misoprostol is a drug that has been, okay, misoprostol is an abortifacient. Yes. It is mifepristone. Mifepristone has been used and as an emergency contraceptive. So, misoprostol is anyways out. Okay. All right. So, clear with this question? Few important pointers regarding emergency contraception. Please remember that. Okay. Till how many days is IUCD used as an emergency contraception? It can be used after it can be used after 5 days also, but then again the effectiveness will decrease. So, preferably within 5 days. Okay, preferably within 5 days. 5, even within IUCD, preferably within 5 days. Okay, preferably within 5 days, because sperms are inside the genital tract and they can remain viable, no, so they may fertilize. Even though if it is here after 5, okay, now see, you are getting confused. You are saying here it is mentioned after 5 days of unprotected intercourse. She wants emergency contraception. Okay, so you have the option most preferred method IUCD, no other method will be there. Hormonal methods are anyways out. Even though she is coming after 5 days, just there she is coming. Why will you deny her emergency contraceptive? You can tell her that the efficacy may be reduced. Yes. Okay. Misoprostol is not used for emergency contraception, bache. If we are talking about emergency contraception, misoprostol is abortifacient. All of these emergency contraceptive methods, they are not abortifacients. All of these emergency contraceptions, they prevent a pregnancy. If a pregnancy has already happened, they are not going to abort the pregnancy. They are not abortifacients. Okay? Fine? All right? Clear? Now, next question. A couple is being evaluated for infertility. They have been trying to conceive for past 4 years. The husband's semen analysis is normal. Woman is 32 years. BMI is 30 kg. Per meter square, cycles are regular. So, you have infertility, okay, obesity, cycles are otherwise regular, severe congestive dysmenorrhea, that's Another important point, so keywords: infertility, dysmenorrhea, fixed retroverted uterus, nodularity in pouch of Douglas. These are the examination findings. She has undergone multiple cycles of ovulation induction in the past. What would you like to do next? Yes. See, testing for cervical factor is anyways obsolete now. We are not doing it in clinical practice. Okay. Performing MRI pelvis will give no additional advantage. First of all, in this question, the suspicion or the diagnosis is that of endometriosis. Okay. The classic triad is infertility, dysmenorrhea and dyspareunia. Dyspareunia is not mentioned here, but the findings of fixed retroverted uterus, nodularity in pouch of Douglas is going in favor of endometriosis, right? Multiple cycles of ovulation induction have been done, already done. So first of all here, we have to rule out and confirm if there is endometriosis, right? The gold standard for diagnosis of endometriosis is laparoscopy. So laparoscopy I will prefer to do. Also, this is patient with infertility. Okay, before planning treatment, it is important to check if the tubes are open or not. Isn't it? Tubal factor can be there simultaneously. There can be element of PID also. I don't know. We have not looked inside the pelvis. So laparoscopy helps us looks inside the pelvis, look for evidence of endometriosis, look for evidence of pelvic inflammatory disease, look for the condition of the fallopian tubes, and at the same time we can do a laparoscopic chromoperturbation also. We can check the patency of the fallopian tubes in the same sitting. We can check whether the tubes are open or not in the same sitting. So, two things can be achieved in this particular patient. That is why the answer is performing laparoscopy, right? Because if the, see, when you say intrauterine insemination, when you say intrauterine insemination, we are talking about putting the semen, washed and prepped semen inside the uterine cavity. But the fertilization still has to be done in the tube. Na? So, for IUI, for intrauterine insemination, tube should be open. So, before doing IUI, it is very important that I check whether the tubes are open or not. Otherwise, the whole process of IUI is a waste of time and money. So, this is not the answer. So, the answer is performing laparoscopy. Alright. Now, so you answered, all of you answered this question correctly. Now, let's have a look at some classic images. Okay. You can have endometriosis related questions. Very important to note the classic ultrasound image. This is an ovarian mass. It is an ovarian cyst with a typical ground glass appearance. Okay, so this is typical of endometrioma. Another name for endometrioma is this. This is the image of this particular patient which we saw on laparoscopy. Chocolate cyst filled with old collected blood, hemosiderin-laden macrophages. And these are the endometriotic deposits which we can see in the pouch of Douglas. Superficial deposits can be there, right? And very subtle lesions can be there, and blackish nodules, fibrosis, powder burn deposits can be there. All are shown in this image. Okay. So, there can be this laparoscopic evidence of endometriosis. Keep these images in mind. Also remember that when we have a chocolate cyst, okay, when we have pain as the main symptom, treatment for pain when we are doing, please remember that medical treatment is tried first. Please remember that medical treatment is generally tried first. And when we have a chocolate cyst, okay, when we have a chocolate cyst that is more than 4 centimeter in size, or that is not responding to medical management, okay, pain is not responding to medical management, then we go for the surgical management. And surgical management is preferably a cystectomy. preferably a cystectomy. Preferably a cystectomy. Okay. Now, also have a look at these two images. Can you identify spotters? These are spotters. These are image-based spotters. I will give you a clinical context along with the images so that you remember. Okay. So, this is a woman who was presenting with, let's say, infertility. Okay. Young woman with infertility, history of episodes of PID in the past. Okay. Physical examination normal. Ultrasound pelvis shows adnexal mass. Okay. Cystic, right, filled with clear fluid, and this cogwheel sign. Yes. Now, likely diagnosis. That is what they are going to ask you, right? That is what they are going to ask you. What is the likely diagnosis now? Very good, multi-star. Are Baba, Sakib, PCOD, PCOS. So, the first question we did in the session today was PCOD. Where are the multiple follicles? Why are you missing out on the clues? Why are you missing out on the history of PID? Okay. If there are polycystic ovaries, ultrasound characteristic of polycystic ovaries would be described. Here there is a cystic lesion, fluid filled, cogwheel sign. Diagnosis is hydrosalpinx. Okay. Another image showing hydrosalpinx. Look at this. This is the same patient. This is the laparoscopic image. See the dilated tube filled with the blue dye. What is this blue dye? This is the methylene blue dye. Okay. So, I am doing laparoscopy at the same time during laparoscopic chromoperturbation. Laparoscopic chromoperturbation I am doing. Right. So, this other side tube was open. That is why the dye came inside. Okay. So, then this laparoscopic chromoperturbation, the methylene blue dye is introduced via cannula from the cervix, and the dye goes inside the uterine cavity, comes out of the fallopian tube into the pelvis. We can visualize at the same time with laparoscopy, right? So, laparoscopic chromoperturbation is showing these findings. At the same time, I can see which tube is open, the affected tube is open or not, or the other side. In this particular case, the other side tube, the unaffected tube was open. So, the dye came inside the pelvis. But this particular tube was damaged, right, had a hydrosalpinx, right. So, like you said, yes, laparoscopic chromoperturbation will help me look for adhesions, will help me look for evidence of endometriosis also. Right. Now, look at this image. Again, the clinical context I will give you. Clinical context of infertility, young woman, right. And again, physical examination normal I give you. Physical examination normal I give you. Okay. And I tell you that HSG was showing, hysterosalpingography was showing blocked tubes, bilateral blocked tubes. I did a laparoscopy. Can you identify the lap image? Excellent. This is tuberculosis. This is genital tuberculosis. Look at the beaded tubes, bead-like tubes, thickened tubes, right? And look at these white tubercles. Okay, look at these white tubercles. They can be present on the serosal lining of the fallopian tube. They can be present on the uterus serosal lining also. White tubercles, multiple white tubercles. So, this is lab evidence of genital tuberculosis, right. So, again, in a patient with infertility where HSG or the clinical history is making me think that there can be a tubal pathology, best way, gold standard for evaluation of tubal pathology, laparoscopy. And in the same sitting, we do a laparoscopic chromoperturbation, isn't it? So, these images help you understand these important clinical pointers, right. So, yes, gold standard for evaluation of tubal pathology when you have infertility is laparoscopy, because you see the tube, you see the condition of the tube, you see the condition of the pelvic adhesions, and you can also do at the same sitting chromoperturbation so that you can confirm whether the tubes are open or not. Right, but also remember that there will be a clinical context in which we do laparoscopic chromoperturbation, because laparoscopy, again, patient has to be anesthetized, GA, patient will be admitted, it will add to the cost of the procedure, it will become invasive procedure, right. So, it will not be the first line evaluation, but you will have to have an indication as to why you are going to go ahead and do the gold standard evaluation of tubal pathology. Now, next, important HSG spotters, identify the cannula. Identify the cannula used for HSG. You tell me the timing of HSG. HSG is a screening test for tubal patency. It is a screening test for tubal patency. This is not a Carmen cannula. This has serrations here. This end goes inside the cervical canal and stays there, you know, it's gripped there, stays there, gripped there, and a dye is introduced, radio opaque dye. This is the cannula I use for chromoperturbation also. This is the cannula I use for HSG also. This is Leach-Wilkinson's cannula. The timing of HSG is any time between day 5 to day 10. Anytime between day 5 to day 10. Generally, we try to call her on day 10 because by this time the bleeding also has stopped and everything, right? The bleeding has definitely stopped. So, day 5 to day 10 we can do it. Basically, it is done post-menstrual. It is done post-menstrual after the periods are over. Keep that in mind. Now, HSG image on the left, what can you see? These are bilateral distal tubal blockage. Bilateral distal tubal blockage, most likely hydrosalpinx. Most likely hydrosalpinx. What is here? You can compare with the image on the extreme right. Image on the extreme right is normal. Image on the extreme right is normal, showing free spill of dye. Okay, and what is this image, middle image, showing that it is filling only the uterine cavity, not filling the rest of, not filling the fallopian tube. So, this is bilateral cornual block, bilateral cornual block. Okay, if you have these screening results, then the next investigation should be, how do we evaluate further? First choice answer should be laparoscopy plus hysteroscopy, so that you can do laparoscopic chromoperturbation, look at the pelvis, and at the same time evaluate the uterine cavity also, because most of these patients are we are undergoing infertility workup. And second choice answer, if lap plus hysteroscopy is not given in the option, then laparoscopic chromoperturbation should be your answer. Then laparoscopic chromoperturbation should be your answer. Okay. Now, another HSG spotter, clinical context, history of infertility, history of amenorrhea or hypomenorrhea may be given, scanty periods. Okay, all right. And because she was having infertility, this was attempted, HSG was done for tubal patency, and you can see multiple filling defects inside the uterine cavity and no dye is coming out of the fallopian tubes, right. So, what is this here? Yes, this is uterine synechia. This is uterine synechia. So, the possibility of Asherman syndrome is there. Possibility of Asherman syndrome is there, right. Yes, Shivangi, moth-eaten appearance, you will describe it. Sometimes they call it honeycomb appearance also. Moth-eaten appearance, honeycomb appearance. Okay, like that it is described. Okay, There can be history of DNCs. There can be history suggestive of genital tuberculosis. Okay, please remember genital tuberculosis. Genital tuberculosis, most common site, fallopian tube and then endometrium. Okay, most common site, fallopian tube and then endometrium. So even endometrium can be involved with genital tuberculosis. So such history could be there. All right. And best for diagnosis of Asherman syndrome, again, hysteroscopy. Hysteroscopy. And we can go for hysteroscopy guided adhesiolysis. That would be the treatment. That would be the treatment. Okay. Right. Next question. Which of the following is not typically used as ovarian reserve test in women undergoing evaluation for infertility? Not used typically. This is a recent question in INICET and they have been asking you questions on infertility workup a lot. So, yes, you are answering correctly. AMH, low AMH means poor reserve. Low AMH means poor reserve. Okay. FSH on the higher side will mean poor reserve. Okay. Estradiol alone is not typically used because estradiol levels tend to fluctuate a lot. Okay. And initially estradiol levels can be higher and and they will take a long duration of time to drop down. Right. So, estradiol levels are not typically used, but yes, we do use the ratio of FSH or estradiol. We consider the ratio of FSH to estradiol more than isolated serum estradiol levels, right? So, this is again a deeper question, but please remember that by alone it will not be very helpful. So, serum AMH, serum FSH, yes. Antral follicle count on TVS, yes. We will also check. Okay, we can check. So, a combined antral follicular count in both the ovaries combined less than 4 would mean poor reserve, and this is generally done on day 3 antral follicular count. Best test for ovarian reserve and something that is we do most often clinically is serum AMH. It can be done any time in the month. It can be done any time in the cycle. Less than 1 nanogram per ml is poor reserve, right? Please remember, when we say serum FSH, when we say serum estradiol, we are talking about day 3 serum FSH and day 3 serum estradiol. Alright, so estradiol alone typically does not give us much relevant information. FSH estradiol ratio on day 3 can help us, right? And in routine clinical practice, generally serum AMH is what we are doing, okay? Next question. 25-year-old man is being evaluated for infertility, has azoospermia. Normal size testes, hormone levels are also normal. What could be the reason? Yes, azoospermia means absence of sperms in the semen. So, no sperm production is there, either that or no sperms are reaching the semen, either that. Okay. So, think about it, hormone levels are normal. You have to go through the same concepts. What did I tell you? The possibility with azoospermia is that either it is testicular failure, testes are not producing the sperms, right? Or there is pituitary or hypothalamic cause. Okay, from higher up above the signal to the testes is gone, right? So that is why. And the other is obstruction to outflow of semen. So that could be the obstructive causes like epididymal obstruction, vas deferens obstruction, ejaculatory duct obstruction, everywhere along the male genital tract. Broadly, these are there, right? So, same logic that we discussed, if there is outflow problem, hormone levels are normal. If there is testicular failure, there is testosterone deficiency, because of which FSH levels are high. If there is a pituitary hypothalamic cause, FSH levels are low, and that is why testosterone deficiency is there. Okay, so here FSH and LH levels are normal. Coleman syndrome again can happen in male also. Deficiency of GnRH, deficiency. Coleman syndrome will be pituitary and hypothalamic cause. So the hormone levels are going to be low hormone levels. Klinefelter's syndrome, 47XXY. In this we have small atrophic testes. Gynecomastia can also be seen. There is testicular failure. So testosterone deficiency and FSH levels will be elevated. Carter syndrome is immotile cilia syndrome. Right. So here also the hormone levels would be normal, but immotile sperms and semen are seen. Right. So most likely answer would be, best answer would be obstructed vas. Best answer would be obstructed vas. Okay. Now if they ask you this question, best to differentiate. Yes, Carter syndrome, Irfan, you are right. There can be, this Carter syndrome actually has a triad of bronchiectasis, situs inversus and male infertility, isn't it? Because cilia are immotile, right? Now, if they ask you how to differentiate between obstructive versus non-obstructive azoospermia, ideally we have to go for a full hormonal profile. But if you have to pick one, best answer is FSH. Right? So ideally full hormonal workup is needed for azoospermic male, but if you have to pick one hormone, then pick FSH as the answer. Next question. 28-year-old woman, para 3, live 3, presents with something coming out of the vagina for past 1 year. Okay, so she is young, she is multiparous. Okay, there is uterocervical descent beyond the introitus, there is prolapse, yes. Okay, uterocervical descent is there. There is no cystocele, no rectocele or enterocele. What is the most acceptable management option? Yes, most acceptable management option. 28-year-old, no hysterectomy. Okay, colpose suspension is surgery for stress urinary incontinence, like Birch colpose suspension. So, colpose suspension is surgery for SUI, not for prolapse. Leaford repair is for prolapse. Leaford repair is when the anterior and posterior vaginal walls are closed together. So, basically it is for women who are not fit for major surgery, but they are not menstruating, otherwise how will the blood come out, and they are not going to be sexually active, then only this will be done. So, best option, Fothergill's repair. It is also called as Manchester repair, Manchester surgery, it is the same thing. Okay, Fothergill's, Manchester surgery, it's the same thing, right? So, family complete is important here, because in this the cervix is amputated. Right? So, for women who want to have future childbearing, so for nulliparous woman, we will have the sling surgeries. Okay. So, sling surgeries are done by various surgeons. There are various surgical names to that: anterior sling, Shirodkar sling, Purandir sling. Many sling surgeries are described. Knowing their names is good enough. So, sling surgeries are there. There is also mesh surgery, which is called as sacrohysteropexy. Right. So, sacrohysteropexy or sacrocervicopexy. right? So it is also a modification of the sling surgeries where the mesh is used. So for nulliparous women, we cannot amputate the cervix. Please keep that in mind, right? Now, what about comorbidities? Like I said, if there are comorbidities, see, if a woman is not fit for a major surgery, then leaf wart repair can be given. But sometimes the woman may be very old and she may be, completely unfit for surgery, right? Then we can go for somebody who is, I'll write it here, okay, I'll write it here, somebody who is absolutely unfit for surgery or does not want surgery, not willing for surgery, for whatever reason, surgery is absolutely a no, okay, or there is a pregnant woman with prolapse, then we can go for pessary. Now, this pessary is not going to be a definitive treatment strategy, but just a temporary thing, right? Now, in this image, what we are seeing prolapse. Can you see here? This is the cervix, right? Coming out of the introitus, right? This is the anterior vaginal wall. And this is the decubitus ulcer. This is the decubitus ulcer, okay? Please remember treatment they have asked, you people, treatment of decubitus ulcer they have asked is glycerine and acreflavin packing. Glycerine and acreflavin packing. Please remember this. So, as first we let the ulcer heal and then only we plan for some surgical repair. Okay. Also remember, if it is a postmenopausal, old woman, postmenopausal woman with prolapse, what's the surgery? Vaginal hysterectomy with pelvic floor repair. I am writing in short, vaginal hysterectomy with pelvic floor repair. Pelvic floor repair means cystocele repair, enterocele repair, rectocele repair, all that will be included. Okay. Here in this image is what we are seeing, the prolapsing anterior wall of the vagina. Prolapsing anterior wall of the vagina. They could mention with the image, they will have to tell you some pointer. They will tell you that she is having difficulty in urination. They may tell you she is having stress urinary incontinence, some urinary symptom, because this is the anterior wall of the vagina that is prolapsing, behind which will be the cystocele, behind which will be the cystocele. Okay, so please remember, and yes, you are right, you are saying decubitus ulcer is a venous congestion ulcer, and that is why we have to reposition it. That is why we have to reposition it. Now, how to differentiate with uterine inversion? You will see the cervix, my dear. Okay, you will see the cervix, my dear, and also in clinical practice, like you will see the cervix, no, first of all, because uterine inversion is like this, uterus turning inside out, like you wear socks and then you turn your socks inside out. Think about it like that. Okay, so the cervix is here and something is coming out like this. All right. Now, picture looks like imperforate hymen. Arey yaar, imperforate hymen had a bluish bulge at the introitus. I am telling you, with the image, they will tell you something. No, clinical context. They will tell you something, that woman is coming with the complaint of something coming out of the vagina. She will not come with the complaint of amenorrhea. She will come with the complaint of something coming out of the vagina. She will complain of maybe difficulty urinating, stress urinary incontinence, and then this image, if they tell you, then you will say that this is cystocele. Also remember for stress urinary incontinence, please remember for MCQs, first we try pelvic floor exercises. What are these pelvic floor exercises? They are called as Kegel's exercises. Okay, so they can be tried for a couple of months, right? Otherwise, yes, procedure of choice is the mid-urethral slings, which are the transobturator tape and the transvaginal tape. Either of the two is fine, but please remember, mid-urethral slings are nowadays the procedure of choice for SUI, stress urinary incontinence. Okay, so again, from you people in FMGE, they ask you most of the times the name of the surgeries and where that surgery is done. Also remember in recent exam they had mentioned Meckel's scaldoplasty. Meckel's scaldoplasty question was asked. Now Meckel's scaldoplasty is basically for enterocele repair. Okay, so whenever we are doing a prolapse surgery, okay, we have to at the same time go for enterocele repair also, because most of the times these prolapse happen together. No, a woman will have cystocele also, enterocele also, uterocervical descent also, right? So whenever we are doing prolapse surgery, whether we are doing vaginal hysterectomy with pelvic floor repair, we will add this particular step, Meckel's scaldoplasty, where we repair the enterocele, So remember this name, Meckel's scaldoplasty. This is for enterocele repair by the vaginal route. So when we are doing vaginal hysterectomy with pelvic floor repair, if simultaneously we want to go for enterocele repair also, we will add this step which we call as Meckel's scaldoplasty. Right? So broadly, all pointers regarding prolapse surgery you should remember here. Next question. Multiparous seen in OPD at 22 weeks gestation requesting MTP for failure of contraception. In which of the following questions can MTP be done in this case? So it's a trick question. Let's see if you can answer this question. Siddharth Shirodkar's is a modification of Manchester where the cervix is not amputated, but the cardinal ligaments are plicated in front of the cervix. So Shirodkar's modification for Manchester was mentioned for nulliparous woman, but nowadays we have sling surgery, sacrohysteropexy, so we're not really doing Shirodkar's modification. Right? So correct answer is yes, option number B, can be done if fetal has congenital anomaly. So please remember that up till 24 weeks it is allowed now. Up till 24 weeks it is allowed now. Between 20 to 24 weeks, 2 registered medical practitioners have to consent. Till 20 weeks, 1 registered medical practitioner consent is enough. For failure of contraception, only till 24 weeks, only till 20 weeks, only till 20 weeks it is allowed. Okay, so between 20 to 24 weeks, we don't need opinion of 2 registered medical practitioners. For the indication of failure of contraception, it will not be allowed, but in case she has a fetus with congenital anomaly, then it can be allowed. Okay, after informing medical superintendent, not needed, and after permission of medical board, one can do beyond 24 weeks. There is only one condition, that's why I am highlighting it. Only one condition where we can do beyond 24 weeks. If there is a gross congenital anomaly, but only after approval from the medical board. Only after approval from the medical board. This is the only situation where the upper limit of 24 weeks can be relaxed. So all in all, up till 24 weeks it is allowed. Okay, fine. And up till 24 weeks, it is allowed in cases of, let's say, rape victims, incest victims, right? Like that, gross fetal congenital anomaly. So under specific situations, up till 24 weeks is allowed. Not that she will say, I am having contraceptive failure. No, then only till 20 weeks. Okay, so keep this in mind. These are important pointers regarding the MTP Amendment Act. Now, let's have a look at the next question. We have a 1-year-old primey. Okay, why option A is not considered? Because she is 22 now. At 22 weeks, between 20 to 24 weeks, 2 RMPs should give the permission, but she is requesting for MTP for failure of contraception. So, for failure of contraception, even if 2 registered medical practitioners say, you cannot allow. Even if 2 say, 3 say, 4, whatever. So that is why this is not a better answer. That's why I said it's a trick question. Okay, so it can be done if there is fetal congenital anomaly, then yes, between 20 to 24 weeks it can also be done, provided that 2 registered medical practitioners are going to give consent. Clear now? That's why I said it was a trick question. So better answer option number B. Coming to the next question. 21-year-old primey, 2 months amenorrhea, cramping lower abdominal pain, light bleeding. See, single live intrauterine pregnancy corresponding to 8 weeks with closed os. What is the preferred management in this case? What is the preferred management in this case? Yes, preferred management. You give me the diagnosis and then you will give me the Rushi. What if there is no fetal congenital anomaly? Then it cannot be done. Then it cannot be done for failure of contraception. You will have to fit into the specific indications where it can be done between 20 to 24 weeks. If there is history, if the pregnancy has resulted out of rape, out of incest, out of, if there's a gross fetal anomaly, or sometimes in disaster situations which are specified by government, or sometimes, when there is change of marital status during ongoing pregnancy, there are certain specific 4 or 5 indications when between 20 to 24 weeks is it is allowed. Okay. So this is, yes, diagnosis is threatened abortion, right? And what is the preferred management now? What is the preferred management now? Priya, if question is according to MTP Act, till when is MTP done? Blanket question, till what POG MTP is allowed by the MTP Amendment Act? Till 24 weeks. Blanket question. Okay, till 24 weeks. But between 20 to 24 weeks, there are certain indications only under which MTP is allowed by law. Okay, fine. So yes, the correct answer is rest and progesterone. It is a live intrauterine pregnancy. It's just a threatened abortion. There is no need for offering MTP. Why will you offer MTP unless the woman says that I want an abortion? So misoprostol, no. Estrogen progesterone therapy, no role. Bed rest is more important, not progesterone. More important is bed rest. Okay, if bed rest and progesterone were 2 separate options, bed rest is more important option. Okay, so bed rest and progesterone is what is given. HCG injections also have no role. Okay, so with threatened abortion, pregnancy can continue, and we can also give support with progesterone treatment. Okay, we can also give progesterone treatment. Okay, these are basically vaginal progesterone suppository. Progesterone tablets can be given vaginally by the vaginal route, or they can be given as oral tablets also. So generally this is micronized progesterone. Ayush, they will mention if they are saying that there is a congenital anomaly in the question. Okay, they will mention. Okay, so Ayush, let's see this question. I think there is some doubt. Let me just rephrase the question. Okay, Ayush, and some other of you are having doubt. She is saying requesting for MTP for failure of contraception. She's come at 22 weeks. She wants an MTP. She says that you ask her how did she end up conceiving, why is she coming now? She says that I had failure of contraception. Okay, for this particular indication, we cannot do at 22 weeks because cutoff is 20 weeks. Of course, if there is a fetal anomaly, then I may be able to do it at this particular gestational age. That is why. Okay, and Tanya, sedatives unnecessary. Why do you want her sedatives unnecessary? Sedatives are unnecessary. Bed rest is also not strict bed rest. Bed rest doesn't mean that she has to be bedridden. Basically, avoid exertion, avoid intercourse. Right? Bed rest doesn't mean strict bedridden. Okay, fine. Now, also remember one more important MCQ pointer. Also remember one more important MCQ pointer. They ask you about missed abortion. They ask you about missed abortion. Or they may say early pregnancy loss. Right? That's why I'm coming here. Threatened abortion means, bache, threatened abortion means, and I have done this in so many sessions. If you see threatened abortion, bleeding is scanty, just mild. Pain is off and on, maybe there, may not be there, off and on. Vitals are definitely stable. The size of the uterus is going to correspond to the period of gestation. The os is going to be closed because right now there is just a threat of abortion and the process of expulsion has not started. Os has not started to open up, bleeding has not started to happen excessively, just the threat of abortion is there. Entire pregnancy is still inside, fetus or embryo inside, cardiac activity present, it's a live, healthy pregnancy. It has to be confirmed on TVS. Management is conservative. Okay, inevitable means now there is no going back. The process of expulsion has started. Okay, so bleeding is more, pain is more. Depending upon how much blood loss has already happened, a patient may be stable, unstable in either of the three situations. Okay, inevitable, the pregnancy, the fetus, the embryo is still inside completely. So size of the uterus correspond to period of gestation. Okay, os has started to open up. Fetus or embryo is still completely inside the uterine cavity, which can be confirmed on TVS. Whether the fetus is live or dead doesn't really matter. That's why I'm not mentioning cardiac activity. It doesn't matter whether the fetus is already live or dead. Process has started, let it progress, and we intervene as and when the bleeding becomes too heavy. Then we may need to go for surgical evacuation or medical evacuation. Incomplete means part of the products are expelled, part are still inside. Okay, so the size of the uterus is less than the period of gestation because some products are expelled. One situation could be that the os is open and the products are felt in vagina. Products are felt in vagina. That could be one situation. The other situation could be that the os is closed. When you do a transvaginal sonography, there is retained POCs present inside the uterine cavity. Okay, when you do a TVS, there is retained POCs, retained products of conception seen inside the uterine cavity still, and then that needs evacuation of the uterus. With complete abortion, bleeding history will be there, pain history will be there, but now there has stopped. Now the symptoms are no longer there. Passage of fleshy mass may be there. So products getting expelled may be there, history may be there, right? And the period of uterus size is much less than the period of gestation. Os is closed. You confirm on ultrasound that the cavity is empty. Nothing extra needs to be done, right? So this is about the different kinds of clinical presentations of abortion. All right. Now, when you have missed abortion or early pregnancy loss, like somebody mentioned very nicely that this is silent miscarriage because it has been missed. So basically a dead, non-growing embryo or fetus is inside, it has already died in utero and it is not growing in size any further. All right. And the process of expulsion did not start. Right. So she may be asymptomatic or she may be mildly symptomatic. She may have this scanty bleeding or she may have this brownish discharge, some off and on pain. So very mildly symptomatic or simply asymptomatic. The size of the uterus is going to be much less than the period of gestation. The os is going to be closed because the process of expulsion has not started. It went silent, it went missed. So how do you diagnose? On ultrasound, on TVS we diagnose. Remember how you diagnose. You will diagnose how. If there is an empty gestational sac more than or equal to 25 that is how you are going to diagnose. Okay, it is already the gestational sac is already more than or equal to 25 mm in size and it is still empty. Then you will diagnose, or you have a CRL of more than or equal to 7 mm and yet there is no cardiac activity. Then you will diagnose missed abortion or early pregnancy loss. This is mainly an ultrasound diagnosis these days. Okay, fine, clear? All right, so this is how these things are diagnosed. Next question, which of the following is an indication for surgery in ectopic pregnancy for woman who is desirous of other pregnancy? Now, robo-gaming, you're asking about APLA syndrome. APLA syndrome, generally we are going to investigate for APLA if there is history of recurrent pregnancy loss. Then we need to investigate for APLA. Okay? Fine. Now, which of the following is an indication for surgery in ectopic pregnancy? Yes, indication for surgery. Yes, Ayush and Tanya rightly saying ectopic more than 4 centimeters in size. See, if it is an unruptured ectopic pregnancy, we can attempt medical management provided certain conditions are fulfilled. Okay, so for unruptured ectopic, right, we can go for medical management. If for unruptured ectopic, we can go for medical management if the serum beta HCG is less than 5,000. If the size is less than 4 centimeter, right, she has to be stable, there should be no contraindication to methotrexate, and she has to be willing for follow-up, and cardiac activity should be absent in that particular situation. If all of these situations are fulfilled, then we can go for medical management in unruptured ectopic pregnancy. Okay, so ectopic more than 4 centimeter, it should be less than 4. So if it is more than 4 centimeter, it is an indication for surgery in ectopic pregnancy. Beta HCG levels more than 5,000. Patient wants to continue pregnancy. Ectopic patient want kuch nahi. Ectopic, there is no continuation of pregnancy outside the uterus. Okay, please remember also that for ruptured ectopic, always it is surgery. Remember this, surgery is salpingectomy. Okay, always surgery salpingectomy. If the patient is stable, preferably laparoscopy. How we enter the abdomen is another matter. If the patient is unstable or laparoscopy is not available in a stable patient, it is laparotomy. Now, Rahul, you are saying if only cardiac activity, then see, cardiac activity should preferably be absent. If cardiac activity is present, then also we are not preferring to go for medical management. If cardiac activity is present, we are not preferring to go for medical management. However, it is not an absolute contraindication. So, as for now, you should remember that for medical management, all these conditions should be satisfied. That would be the ideal candidate. All should be present. That would be the ideal candidate for medical management. That would be the ideal candidate for medical management. Also make a note that how you are going to differentiate between unruptured and ruptured tubal ectopic. See, vitals very, very important. Ruptured tubal ectopic, unstable vitals will go more in favor of ruptured tubal ectopic. Pain is also going to be more generalized when it is a ruptured tubal ectopic, and abdominal distension can be there, fluid thrill can be there, because now the blood has collected inside the pelvis. So, hemoperitoneum. So, signs and symptoms of hemoperitoneum, if present in the form of abdominal distension, in the form of fluid thrill, will go in favor of ruptured ectopic. Bluish discoloration around the umbilicus, C for center, C for Cullen's. In the flanks, grey Turner sign. Turn the patient to one side and then look at the discoloration. Shoulder tip pain is Danforth sign. Okay, so name of these signs is important. They have been asked in FMGE. The important concept here is these are signs of just hemoperitoneum. In this particular case, the hemoperitoneum is happening because of a ruptured ectopic pregnancy. Okay, and these signs and symptoms of hemoperitoneum are going to be absent in unruptured ectopic. On PV examination, uterus is normal size, tender adnexal mass, cervical motion, tenderness. These are things that will be appreciated if it is unruptured ectopic. If it is a ruptured tubal ectopic, we may just find bogginess felt through the fornices. Bogginess is felt through the fornices, right? Because again, hemoperitoneum is collecting. So when we are doing the PV, we are not able to appreciate anything much, but just this fullness felt through the fornices. Ultrasound is the investigation of choice. Ultrasound can show hemoperitoneum. Most importantly, ultrasound will show uterus empty. Most importantly, the biggest clue, the first clue would be that the uterus is empty. And we can find other findings. We can find gestational sac in the region of adnexa. We can find a complex adnexal mass. We can find bagel sign, blob sign. So these ultrasound features can be there. In unruptured, do we need to remove the tube? We can attempt to save the tube also. So in case we have unruptured ectopic, in case we have unruptured ectopic, okay, and we are going for surgery, okay, there are two options. One is salpingectomy and the other option is salpingostomy, where we can save the tube. So depending on case to case basis, we can go for salpingectomy and salpingostomy also. We can attempt to save the tube also in patients with unruptured ectopic. All right. Now next question. Okay, before we attempt the next question, and we have, let's say, how many questions to go? We have OBS questions to go to, the major OBS questions. So they are not much. They're not much. But again, since from one question we are going to do multiple questions, that's why we're taking much time. Okay, so let's take a break for 10 minutes. Prem Kishore, is it enough for upcoming exam? It is covering most of your PYQs for the upcoming exam, right? But if you want to look at extra, I would advise you to go through more of LRR sessions. One LRR session was done for NEET PG also, and for INI CET was also done, which was mainly more clinical and more aggressively clinical. So that would be there. So for now, let's take a break for 10 minutes and we will see each other in 10 minutes, okay? So we have a certain chart happening here, and one you've asked that why methotrexate is not a drug of choice for ruptured ectopic, because the tube has ruptured. Right, there's no salvaging a tube that has already ruptured. So the only way you're going to control bleeding is by removing the affected tube and closing off the source of bleeding. You can't go for medical management there, right? That's why. And doing the rapid revision videos plus LRR. See, LRR, the sessions that we have on YouTube, the thing is that we try to cover as many questions as possible, but then you have to understand that LRR will not cover all of your questions. So if you want LRR to cover the length and breadth of the questions, you'll have to maybe see a couple of LRRs. That is why I'm telling you that they're all live on the YouTube platform, right, with the PrepLadder app. So you have the LLRs that are being conducted before every exam. If you see all of them, yes, you can brush through them. If there's some question that has already been discussed, you know about it already, you can skip that part. But again, I would focus at this point in time doing more and more of questions and revising retrospectively, right? Because again, you have to cover as many questions as possible, because the exam is in, like, in January now. So that would be my advice to you, that instead of reading A to Z from cover to cover, it will be better that you go smartly and do the previous year questions, previous year topics. When I say previous year topics, yes, somebody asked that do they give the exact questions? No, they do not give you the exact questions. You are lucky if they give you the exact questions. Most of the times these are recall questions, right? So students only tell us that this question had come, this was asked and everything. But many times, yes, we do expect, majority of the time they will slightly tweak the question. That is what they generally tend to do. All right. Got it? What filter is used for HSG? HSG के filter नहीं, colposcopy is done with a filter, visual filter. It is a green filter. Okay. All right. So now let's come to the next question. So again, I think you've read the question. You've already given your discussion to the question, as I can see right now from here. So 25-year-old Primey, she came at 32 weeks of gestation, and she is sure of her dates. Symphysis fundal height is 28 centimeters. So this is fundal height less than the period of gestation. So first thing that comes to mind could be wrong dates. Yes, but she is sure of her dates. It could be IUGR. It could be fetal death also. Maybe it's a dead retained fetus that is not growing, right? So these could be, or oligohydramnios could be there. So these could be the possible reasons. And there is no history of leaking, because if there oligohydramnios is there, that means maybe the liquor has leaked out. That is also a possibility. There is no history of leaking. There is no history of bleeding. She is not perceiving fetal movements for 2 days. At 32 weeks, if she is not perceiving fetal movements, I don't know, the baby could be dead. I don't know. It could be a growth restricted plus a dead baby also. Who knows? So the first thing that you have to do is you have to see if the baby is alive or not. FHS cannot be localized on stethoscope, right? So FSH is not localized on stethoscope. So possibility there is that maybe the baby is already dead. So now you have to go for ultrasound. On ultrasound, you are going to see the cardiac activity, whether the fetus is alive or not. You may see the evidence of oligohydramnios. You will see if there is fetal growth restriction and everything. Right? So a lot of information you will get from ultrasound. So that becomes a priority to do. Not NST, not fetal Doppler, not biophysical profile. Right? So look at the clinical, look at the question and understand it logically. Common sense, that if you are not able to localize on stethoscope only, so first confirm whether there is fetus is alive or not. That becomes the priority, right? So for now, the answer is NST. Why not Doppler? Doppler later. In case I am not able to hear the fetal heart sound. Okay, in this situation, I am for some reason not able to localize the fetal heart sound. I do an ultrasound, fetal heart rate is there, cardiac activity is there, but fetus is growth restricted. Now, for growth restricted fetus, further evaluation, then I will think of doing fetal Doppler. Okay, so it will come next, depending on whether I need it or not. Right? You request a fetal Doppler, doctor does fetal Doppler, takes extra money from the patient. What is the point? You know, you request for one thing at a time. Even when they do Doppler, first they will put an ultrasound probe, na? It is ultrasound Doppler. So, Doppler will be done if it is needed, not right now. Okay? Now, image spotters. Image spotters. You do an ultrasound, you also find evidence of certain signs. Like for example, this sign. What is this sign? This is overriding of skull bones. Overriding of skull bones. That means it may have been a dead fetus and the brain tissues also get macerated. So, long since dead. That is what it means. This is Spaulding sign. Okay. It comes at around 7 days from IUD, 7 days from IUD. So, you can find these signs also, right? What is this on the right? So that you don't get confused. What is this on the right? So that you don't get confused. NST will come to that. All my questions most of the times are linked with one another. Okay, what is this image if you get confused? This is the outline of the skull and this is like a halo around the skull. Halo sign, Buddha sign, scalpedema, seen where? Fetal hydrops. Seen where? Fetal hydrops. Right? So, don't get confused with this image. This is halo sign, Buddha sign, scalpedema seen with fetal hydrops. Okay? Most common cause of fetal hydrops. Most common cause of fetal hydrops. Hydrops identified in the fetus. Most common cause, fetal hydrops. Yes, CVS anomaly in the fetus. Better answer, second most common, aneuploidy in the fetus. Second most common cause, aneuploidy. Most common infection causing fetal hydrops, another MCQ they ask you, parvovirus infection. Parvovirus infection in the fetus. GDM does not cause fetal hydrops. Fetal hydrops is fluid collection in the fetus. Right? So, fluid collection in the scalp is signifying generalized anasarca, right? Ascites, fetus having ascites, fetus having pleural effusion, fetus having pericardial effusion, that is hydropic fetus. Okay? Think about it like fetus is having heart failure. Think about it like fetus is having anemia. So, this is fetal anemia. Fetal anemia, conditions where fetal anemia are there, that will cause fetal hydrops. Right? RH affected fetus, fetal hydrops. Okay? All right? Now, next question. 22-year-old primary sure of dates ANC OPD at 22 weeks. No history of quickening, vaginal leaking, bleeding. Problem is that she's saying I'm 22 weeks, she's not started to perceive fetal movements, there's no leaking, bleeding. Uterine fundus is palpable midway between umbilicus and pubic symphysis. Midway between umbilicus and pubic symphysis. Fundal height corresponds to 16 weeks, less than POG. Urgent bedside ultrasound shows live fetus, AFI 2 centimeter. Oligo. Which of the following conditions could be responsible? Excellent. Renal agenesis. So, fetal kidneys contribute to urine production and this urine is the main component in the second half of pregnancy as far as amniotic fluid volume is concerned. So, broadly remember, conditions where fetus cannot produce urine, So related to kidneys. So there can be renal agenesis, multicystic dysplastic kidney, infantile polycystic kidney disease. Conditions where fetus cannot either produce urine or the urine that the fetus is producing is not coming out. Posterior urethral valve. So conditions affecting the kidneys, kidneys not producing urine, or posterior urethral valve, urine not coming out. These are the sort of abnormalities which are going to cause oligohydramnios. Okay, conditions where fetus is, imagine fetus vomiting inside the womb. Think about it, fetus is swallowing the amniotic fluid, but it is regurgitating it outside, cannot swallow. So congenital diaphragmatic hernia, fetus swallowing affected. Anencephaly, fetus swallowing affected. Okay. Duodenal atresia, esophageal atresia, tracheoesophageal fistula, wherever, think about it, where the fetus is regurgitating, vomiting out the amniotic fluid, it is going to cause polyhydramnios instead of oligohydramnios. In Bartter syndrome, there's a dilute urine that forms, not the amount of urine is not affected. So that's out. All right. So remember this ways. Also, most common anomaly associated with polyhydramnios is what? Most common anomaly associated with polyhydramnios is GIT anomalies and then neural tube defects. Among GIT, most common is, of course, there can be all of these atresias and everything, but apart from that, most common cleft lip and palate. Again, interfere with the fetal swallowing reflex. Okay, so remember these important pointers. Also remember, what is this Potter's triad associated with renal agenesis? Yes, Potter's triad, bilateral renal agenesis in the fetus, and what else? Kidneys are the main contributory. So kidneys start producing urine from 12 weeks onwards. And fetal kidneys, okay, fetal kidneys start producing urine from 12 weeks onwards. From 18 weeks, urine becomes the most important source of amniotic fluid. So early on in pregnancy, there is oligohydramnios. It is going to stay like that, right? So imagine this fetus which is just, packed inside the uterine cavity, and, the fetus's face is, facial abnormalities are there. So facial hypoplasia is there. Imagine a stuck fetus inside, not able to move, limb contractures. Lungs are not able to expand, pulmonary hypoplasia, flat facies. So this is basically Potter's triad. Potter's triad. It is associated with bilateral renal agenesis, right? So remember these important pointers, right? So Bartter syndrome is something that you read up in pediatrics and surgery. It's a disorder where there is problem with the osmolality of the urine, right? It has not got to do with urine production per se. Next question. 26-year-old multiparous, previous cesarean. This is an FMGE question. A term gestation in active labor, pulse rate 110, so tachycardia, BP is fine, good contractions, okay. How you read this question is important, okay. How you read in questions is important. And syphilis, rubella infections, yeah, they can also cause. Fetal infections can also cause polyhydramnios. We were basically talking about the kind of anomalies, but fetal infections can also cause polyhydramnios, you're right, okay. Now, how do you read such questions? When you have clinical questions on management of labor, okay, any clue regarding high risk factor most of the time will be in the first line of the question. If she is previous cesarean, if she is hypertensive, if she is diabetic, whatever, mostly will be in the first line. What are they asking you? Most appropriate management they are asking you. She is in labor. You have to just look at 3 P's. Look at the power, look at the contraction. You have to see the power, look at the contraction, okay, how contraction she is getting, passage, anything given about her pelvis, okay, and passenger, anything given about the fetus. These are the 3 things that you have to focus on. So contractions are good, right? What about the fetus? Look at this, fetal heart rate 120, persistent late deceleration, not okay. Not okay. They are not saying everything is okay. Fetal heart rate is baseline is fine, but persistent late decelerations. cervix is fully dilated, anaphase, vertex at +1 station, sutures LOA, membranes absent, liquor meconium stained. Here, for attempting such question, mainly look at what they are telling you about the station. Mainly look at what they are telling you about the station. Also, if the cervix is fully dilated, fully effaced or not. Right? Which of the following is the most appropriate management? Yes. Now, she's previous cesarean. She's having persistent late decelerations with good contractions. Abnormal fetal heart rate patterns in a woman who is in labor with previous cesarean section. This could be an early sign. Persistent late deceleration, fetal heart rate abnormality could be an early sign of impending scar rupture. So, for me, this is urgent cesarean section. Whatever may have been the pelvic findings, whatever may have been the pelvic findings, for me, this would have been an urgent cesarean section straight away looking at these two clues. Right, urgent cesarean section. Now, let's assume that there is no previous cesarean history. There is no previous cesarean history. Then what we could have done? Maybe previous cesarean history was not there, but similar patient, right? Then please understand here that if contractions are already good, there is no need for oxytocin. You can't make any contractions bestest contractions. Is nothing like it. As long as the good contractions, it's fine. So, oxytocin augmentation is not needed. Membranes are already absent. Now, for instrumental vaginal delivery, station, first of all, fully dilated cervix has to be there. Fully dilated, fully effaced cervix has to be there, right? And membrane should be absent. There should be no CPD, no caput, no molding. No evidence of CPD should be there, no caput, no molding should be there, right? So, there should be no evidence of CPD. These are most important. I am not giving you the list, entire list to remember, but fully dilated, fully effaced, membranes absent, no CPD, and station should be +2 and beyond. So, anyways, this forceps and vacuum is anyways out. The moment I see +1 station, I realize I cannot put forceps vacuum. So, the point I am trying to make here is that when you have such questions, bache, please rule out rather than rule in. Rule out. They are giving you a situation where a woman is in labor, for some reason the labor is stuck, not progressing, or the fetal heart is creating problems. Whatever the situation is, rule out by looking at keywords. So, which of the following is most appropriate? So, do you think oxytocin augmentation would be most appropriate? She's already getting good contraction. I'll say no. Do you think any sort of instrumental delivery would be most appropriate? I would say no. The moment I see +1 station, I'll say I'll not apply. So, by elimination alone, we can come to the answer that it is urgent cesarean section. Okay. Now, only meconium we go for urgent cesarean section? No. No. Meconium by itself is not an indication for cesarean section. Generally in clinical practice, if there is thick meconium, patient is far from delivery, one tends to do a cesarean section. And please don't worry, for your FMGE, tends to do possible, these grey areas generally they don't ask, right? So, meconium, I have never seen a question being asked directly on meconium management, because again with meconium, different clinicians manage differently. Meconium by itself alone, rest all conditions fine, is not an indication for direct cesarean section. Some people may do, may justify, let's not go ahead with the maze, okay? Right? And yes, you are right, engaged head. See, station +2 and beyond agar hai, right? Station +2 and beyond, if it is, it all in itself means engaged head. Please remember engaged head also. Right? So, engaged head hona chahiye. Low forceps criteria is 0 to +2. Na, you're remembering it incorrectly. AJB, you are remembering incorrectly. Low forceps criteria is +2 and beyond. Okay, 0 to +2 is mid cavity forceps. You remember it incorrectly. It's +2 and beyond we are using. And in our clinical practice, we are not doing we are not doing mid cavity, high cavity forceps application. Then there are other important pointers. Also note about instrumental vaginal delivery, some important pointers on which direct MCQs have been asked. With forceps, maternal perineal injuries are more common. With vacuum, acute perinatal injuries are more common. Please remember, these are the absolute contraindications for instrumental vaginal delivery. So, if there is cephalopelvic disproportion, inadequate pelvis or known bony deformities or coagulopathy in the fetus, these are absolute contraindication. There are certain situations where forceps are preferable more over vacuum. Like if we have to apply forceps on a preterm head, mento anterior after coming out of breech or dead fetus, then vacuum is not preferable. These are special situations for forceps. Doesn't mean forceps must be used. It simply means if an instrumental vaginal delivery is being considered in these situations, it is preferably forceps over vacuum. Vacuum is not going to be used here. All right. Now, there are certain injuries which are more typical with forceps because the way forceps are applied. Common sense. So, forceps, blade of forceps causing brachial plexus injury here, causing anterior eye injuries, cornea abrasion, facial nerve palsy here with the blade of forceps, maybe depressed skull fracture with the blade of forceps. So, remember that. There are certain specific injuries with vacuum. Vacuum applied on the scalp like this, suction pressure, right? Suction pressure on the vacuum. So, creates more of trauma to the blood vessels of the scalp. So, more often with retinal hemorrhage, cephalhematoma and subgaleal hemorrhage are more often associated with vacuum. Now, talking about forceps application, outlet forceps application is when we apply forceps at a time when the scalp is visible at the introitus. That means the skull has reached the pelvic floor, the head is at the perineum. These are the definitions of outlet forceps application. Okay. Shivangi, I hope you get your doubt cleared now, right? +2 and beyond, we can go for forceps or vacuum, any kind of vaginal delivery, instrumental vaginal delivery. If I am applying forceps, when the fetal head is at +2 station, but it has not yet reached the pelvic floor, I call it as low forceps application. When I applied the forceps, I did a low forceps application. Okay. When I applied the forceps at a time when the scalp was visible at the introitus or when the fetal skull had reached the pelvic floor, the head was already at the perineum, that sort of forceps application, I call it as outlet forceps application. ठीक है? Clear? So, this is about the forceps application. In FMGE, they have also asked flexion point. Yes, Wrigley's is a type of outlet forceps. Flexion point for vacuum application. Flexion point for vacuum application. So, this is the fetus's scalp. This is the vacuum cup. Okay, this is the vacuum cup. This is the posterior fontanelle. Okay, so vacuum cup is applied here. Okay, somewhere here. So, it is 3 centimeter. Sorry, not 3 centimeter. The center of the cup is here. 3 centimeter anterior to posterior fontanelle. Okay, 3 centimeter. So, this is the flexion point. It is 3 centimeter anterior to the posterior fontanelle. That would mean the same thing as 6 centimeter posterior to anterior fontanelle. This would be the anterior fontanelle here. Right. So, I remember it like this. It is applied somewhere here. It is closer to the posterior fontanelle. This is how I remember it. Okay. All right. So, flexion point question has been asked. Next question. You're asking in which situations do we do NST. NST is a method of assessment of antenatal assessment of fetal well-being. Okay, so certain high risk pregnancies are there where we want to go for more frequent NST like weekly NST. Growth restricted fetuses we may want to do bi-weekly NST, so that depends. Okay, for antenatal assessment of fetal well-being. So that is one situation where we do NST. It's a live fetus that we are monitoring. Now, primigravida at 37 weeks, complaint of decreased fetal movements. Now, this is another situation where NST becomes applicable, where she is not maybe perceiving decreased fetal movements or not perceiving movements, but cardiac activity is there, right? So, there is no history of abdominal pain, leaking or bleeding. Uterus is term size, relaxed. NST is done. So, it's a live fetus. Okay, we must have localized the fetal heart sound. Fetal heart sound must have been there. NST strip is shown below. What is the most appropriate next step? Okay, so what do we see here in this strip? That she is palpating movements. But if you see the baseline, it's fine. Nobody is asking you to judge basically, not too much in detail, but remember that something is not right about it. What is not right about it is the variability is decreased, the zigzag wiggliness of the baseline is not obvious, and no accelerations are there. No accelerations are there. So, for now this is not looking reactive. But before we label it as reactive, we should do it for full 40 minutes. This is for 20 minutes. We do it for 20 minutes initially. Baby can be asleep in utero. That is one very common reason of having a non-reactive NST. So, it is better that we perform for full 40 minutes before labeling it as non-reactive. And that's why the answer is performing NST for 30 minutes. Full 40 minutes is the answer. If NST is non-reactive, then we go for a full biophysical profile to decide, right, whether we should go for delivery and whether we should have wait and watch, and not just biophysical profile. And I'm just giving you a broad perspective. There's no need to mug all this up. Okay, just remember that if the NST is non-reactive, whether or not we will deliver will depend on a number of things. It will depend upon the gestational age also, right? It will depend upon the full biophysical profile also. So, complete workup has to be done later on. So, to begin with, we start with NST in such situations. What is modified biophysical profile? It is NST plus AFI, which is checked on ultrasound. NST plus AFI, which is checked on ultrasound. So, whether we want to go for induction, cesarean, how we deliver, whether we deliver or not, it is another matter. For now, perform NST for 40 minutes and follow up. It's not okay now. We can't send, it is not normal. So, we can't just send her home, right? So, follow up in OPD is also not the answer here. Have a look at this image to understand what normal is. So, what do we see here? This is the toco probe. This is the toco probe checking uterine contractions. This is the cardio probe checking the fetal heart rate, right? NST, non-stress test, okay? NST simply means that patient is not having contractions, the uterus is relaxed, non-stress test. Stress of labor is not there, okay? Stress of labor is not there, that is what it means. Reactive NST means that at least 2 accelerations are there, in 20 minutes, each at least 15 seconds and each lasting for at least 15 seconds and each at least 15 beats per minute. That would be the definition of reactive NST. Okay. Now, when we use the same machine, this is CTG machine, this is cardiotocography machine. Same machine we use to do NST. Same machine we go for intrapartum monitoring of the fetus. Okay, so this is the contraction trace, this is uterine contraction and this is the fetal heart rate trace. So, you can see the wiggliness of the baseline, beat to beat variability Remember, normal should be between 5 to 25 beats per minute. We check the baseline fetal heart rate. Baseline fetal heart rate should be between 110 to 160 beats per minute. Baseline fetal heart rate should be between 110 to 160 beats per minute. Accelerations can be plus minus. Accelerations, if present, is a very good sign. Like for example, here acceleration is there, here acceleration is there, here is also another acceleration, right? So acceleration, if present, is a good sign. There should be no decelerations. There should be no decelerations. So keep this in mind. Okay, and now you are telling me how much we can go for, how, see, CTG machine, we do this trace for intrapartum fetal heart rate monitoring, and for high risk women in labor, where it is very important that we pick up fetal heart rate abnormalities, then continuous cardiotocography is recommended. Okay. All right. Now, look at these traces. What are this? This is acceleration. Sorry, this is contraction. Now, you will have to forgive me a little bit if I make mistakes while I am speaking, because sometimes, especially when it is the last 1 hour of the session, I start mumbling wrong words sometimes. So, you will have to forgive me. I will not write the wrong words, but I may mumble wrong words. Okay. So, these are contractions and this is the deceleration. So, this is an exact mirror image of the contraction. This is early deceleration, happens with fetal head compression. Early deceleration happens with fetal head compression. Remember this. By themselves, it's not very threatening. Early deceleration by themselves, not very threatening. Here, image number 2, these are late decelerations. So, there is a delay. Can you see? This is the contraction. There is a delay in the deceleration. So, these are problem. These are seen with fetal hypoxia and they are also seen with fetal uteroplacental insufficiency. So, these are definitely not okay. And remember this, they can come with contraction, without contraction, after contraction, before contraction, anytime. So, that ways they are unrelated to contractions, okay. So, these are, and they sharply drop down and come back, okay. They are not like a, it's not a smooth drop, it's a very sharp drop and recovery. So, this is variable deceleration and they happen because of cord compression. Very good. So, you need to remember these important pointers also. So far, they have asked you direct questions, but again, image based questions can also be asked from here. Next question. All of the following drugs are used in PPH management except, we are talking about treatment of PPH. Yes. Which drugs is not used? Should we change the position of mother for variable deceleration? You know, you should change the position of mother for any kind of non-reassuring fetal heart rate pattern. It's a very nice question, Tanya, that you're asking, right? See, whenever there's any kind of fetal heart rate abnormal pattern, okay, obviously with variable deceleration, obviously changing of posture, I mean with left lateral position, let's say for example, there's a possibility that cord compression can be avoided like that. Or if there is any cord compression happening, that is avoided. The other thing is when you have a woman lying down in prolonged supine position, supine hypotension, compression of inferior vena cava. What does that lead to? Uteroplacental insufficiency. Why? Because cardiac output decreases, blood pressure falls. Common sense, right? Isn't it? Because placental perfusion will be dependent on how much cardiac output is there in the mother. So, if there is supine hypotension, prolonged compression of inferior vena cava, then placental perfusion is also compromised. Don't we say to pregnant women, Stay in left lateral position. Left lateral position is the best position. Why? Because maternal hypotension is also less and placental perfusion is also better in left lateral position of the mother. Coming to this question, answer, yes. Now see, I knew you would have doubt between tranexamic acid and mifepristone. But yeah, mifepristone is definitely not used. Mifepristone has no role in the management of PPH. Mifepristone is used as a cervical ripening agent in abortion cases. Remember mife plus meso when we give for MTP? Right? So, mifepristone is not used for treatment of PPH. All are used. Oxytocin used, prostaglandin used. Tranexamic also is acid is also used in management of PPH. Tranexamic acid is an antifibrinolytic agent. It is not a uterotonic, but it is a definitive role in management of PPH. And Bachche Tania, tranexamic acid was there in the previous guidelines also. For a long time, tranexamic acid is being used for PPH management, not just about the recent update. However, I will touch upon the recent update also. Before I touch upon the recent update, please also remember here one thing, okay, that how do you define PPH remains the same. Okay, what the WHO latest, we are talking about WHO latest 2025 update. What they are saying is that when to initiate, when to start the first response, when to get active. And I've been saying this again and again in my lectures, and I keep telling you, and this is something that WHO may have used, incorporated in the guidelines now, but we've been following it for a long time now, that any amount of bleeding, it may because the visual estimation of blood losses could often be incorrect. Okay, any amount of bleeding that is making the woman symptomatic, we act immediately. Right, the moment there is excessive gush of flow, we start acting immediately. Right, so to start the first response treatment, we don't have to wait too much. If there is more than or equal to 300 ml blood loss, now they are saying that objectively estimate blood loss by using those gauzes, which are there are drapes, which calibrated drapes we may call them, where all the blood collects underneath the drape. There's a collecting box there. So quantification, objective quantification they are saying. So more than or equal to 300 blood loss plus any. What any? Altered hemodynamic status, pulse rate more than 100, systolic BP less than 60. You know this is already tachy and this is hypotension, this is the definition, right? And shock index more than 1, shock index more than 1. So, if any of the following, start the first response, or blood loss more than or equal to 500 ml, then we start the first response, then we don't wait for the hemodynamic status to worsen, that it will worsen, then we will act, right. So, this is the change, that whichever occurs first within 24 hours after birth. Within 24 hours after birth, then we start responding. Okay, we start acting. This is the update we are talking about. Okay, now what about the uterotonics? Okay, now this is again a chart of uterotonics that I often discuss in my lectures. Okay, now again, this is what the WHO is saying. We will have to incorporate it in our guideline. For now, we have not done. And again, if you read the ACOG guideline, they will be different. So, the drugs are the same. What you need to remember is that oxytocin is still the drug of choice if you talk about active management of third stage of labor or PPH. Oxytocin is still the drug of choice. WHO now latest is saying methergin not for AMTSL. And syntrometrine and carboprose, they were never for AMTSL any which ways. They were never there for AMTSL any which ways, right? So, now WHO is saying oxytocin, misoprostol and carbitocin. WHO is saying oxytocin drug of choice, which was already drug of choice. They are saying if oxytocin cannot be used, cold chain of oxytocin cannot be maintained, then carbitocin heat stable alternative is there, that should be procured and that should be made available. So, oxytocin, carbitocin, and then for situations where there are lay healthcare workers, not trained, unskilled. Okay, for them those people cannot give IV, any drug, IV or IM. For them, oral misoprostol. This was there earlier also. Same thing, right? Now they have removed methergine. I always used to tell you that we anyways don't use. Have you ever seen anybody in labor room? If you have ever attended any posting, you will know for active management of third stage of labor, you will never see any one of us giving methergine. Right? From the day I was doing my PG, we have never given methergine for active management of third stage of labor. The risk of side effects like hypertension, the increased risk of retained placenta, we were anyways not giving. Now they have incorporated in the guideline also, right? Yes, carbitocin is not used for PPH treatment. Symptometrine can be used for PPH treatment. Carbopros can be used for PPH treatment. Now, IV infusion, WHO new is saying that IV diluted can be given over 1 to 2 minutes. But they are still saying no IV bolus. Diluted by slow IV can be given, but no IV bolus. IV bolus undiluted rapidly given is still a big no. So, those things have not changed. Alright. Now, also remember, yes, Afzal Siddiqui, carbitocin is synthetic oxytocin. Yes, it's a long-acting analog of oxytocin. And also remember, I'll come to this in a while, these images in a while. Also remember what is involved in the first response, right? And this is the same that I've been teaching you. IV fluids, yes, crystalloids are preferable. You all know this for hemorrhagic shock. Uterotonics, you will start. You all know that. Drug of choice, oxytocin, I have told you. Tranexamic acid has to be given whatever be the cause of PPH. It doesn't matter if it is atonic PPH or what kind of PPH, preferably within 3 hours, then it is more beneficial. Tranexamic acid, right? Uterine massage. Somebody will do the uterine massage to make the uterus contract, and what will you do? You will explore. Explore for genital tract trauma and completeness of placenta. This has to be done within the next, within the first response. It has to be initiated in the initial 5 to 10 minutes. Catheterization of the bladder is going to be another thing. This is the first response. Alright. Now, you are going to use uterotonics systematically. Yes, you can use for PPH treatment. This is for PPH treatment. So, drug of choice oxytocin. After that, depending upon whether contraindications are there or not, it's methergine we use. We can use misoprostol. We can use carboprost. Right. Now, once the uterotonics are exhausted, okay, let's say uterotonics we are giving repeatedly, we are giving uterotonics. Please remember this chart I have discussed with you. All the highlighted pointers are on which questions have already been asked. Okay, let's go a little bit conceptual. Okay, you are exhausting the uterotonics one by one. You are giving whatever was available to you, right? Obviously, in the meanwhile, the uterus is still relaxed. So, what are you doing? Either you are massaging continuously or you are doing this bimanual uterine tamponade. So, this bimanual uterine tamponade is a temporizing measure. Okay, I'm doing this to rub up a contraction to decrease bleeding, right? Meanwhile, preparing other things, preparing for blood transfusion, preparing for OT, informing, calling for help, this and that, other things. So, yes, this is a temporizing measure. See, and look at this. This is the Bakri balloon. This is our jugaad of a Bakri balloon condom catheter. Right. So, depending upon, yes, I have told our staff, okay, get ready with the Bakri balloon if it is there, or get ready with the condom catheter if it is there and if you know how, right. So, meanwhile, we are doing the balloon bimanual tamponade, the apparatus for condom catheter insertion, Bakri balloon insertion is getting ready, right. And we come to this tamponade, this we call as balloon uterine tamponade. We call this as balloon uterine tamponade. Okay, this is to be done for atonic PPH. This needs to be done provided that the uterus is empty. There is no retained products. We have to ensure that the uterus is empty. Please remember that. And it has to be done, it is preferably done with vaginal delivery, post-vaginal delivery. Preferably done with post-vaginal delivery. Why? Because it helps avoid a major surgery. Look at it logically, it helps avoid a major surgery. That is the important point to note here, that in case this balloon tamponade is successful, we avoid a major surgery or a laparotomy. Simultaneous resuscitation is an ongoing process during management that keeps going on. On this also question has been asked. Balloon uterine tamponade ideally should be done in OT, so that if the procedure fails, I have the patient already in OT and I can immediately go for surgical management, but this is something that we attempt in LR also. It can be done in LR also, okay, but ideally should be done in OT, all right. Now, if these tamponade methods are working fine, otherwise we'll have no option but to go for a laparotomy, surgical method. Surgical method will all begin by emergency laparotomy. Please remember that when you have atonic PPH, preference is given to the compression sutures. Okay, and this is B Lynch in the image. B Lynch will be asked because B Lynch is what we are all trained in, right? Now look, tamponading, what you were doing, compressing, this is also what you are doing. This was temporary. Bimanual uterine tamponade was temporary. This is when you are placing a suture, you are achieving the same thing. So, surgical laparotomy will be needed. Atonic PPH, we can go for compression sutures. These will be preferable, right? And then we have this uterine artery ligation, ovarian artery ligation, internal iliac artery ligation. They can also be attempted, but they are going to be time consuming. They are generally not preferable. For atonic PPH, it is compression sutures which are preferable. Now, what question has been asked already? They are saying that you are doing a cesarean section. Supposing I am doing a cesarean section, patient is already open. She is having PPH. I have used all the drugs available. Uterus not contracting. I am massaging, uterus not contracting, used all the uterotonics. Now what? Patient is already open. Surgery is already going on. Cesarean was being done. So now, yes, post CS, if you are having, then compression sutures will be preferable. But surgical methods, right, or balloon methods will come once the uterotonics have been exhausted. All right. So please remember these important pointers. All right, I have given you the gist. All right, otherwise only PPH we can discuss for an hour, but that's not the point. We have to go for a rapid revision. All right, so the rapid revision is that balloon tampo, when the first response bundle is exhausted, this is the first response bundle, let's say. Once this bundle is exhausted, post-vaginal delivery, we can try for the balloon tamponade, intrauterine balloon tamponade. But let's say we are already doing a cesarean section and then PPH was happening and then the first response bundle was exhausted. Obviously, then compression sutures, we can resort to compression sutures. And obviously, hysterectomy becomes the last resort. Sometimes we'll have no choice but to end up with the hysterectomy. Right. Also remember that uterine packing is not recommended. Uterine packing with gauze pieces, not recommended at all. Please remember this. No uterine packing. Now, active management of third stage of labor according to WHO, uterotonics to be given immediately after delivery of the baby, preferably within 1 minute. And please remember, I am marking a star point, you have to keep it in mind that active management of third stage of labor starts once all the babies are delivered. Okay, so if it's a multiple pregnancy, once all fetuses are delivered, then, so after delivery of all the babies, will the active management start. Okay, preferably within 1 minute. Drug of choice is oxytocin, and please remember, as per the Government of India guidelines, it's 10 units IM. Okay, it's 10 units IM as per as the Government of India guidelines. Delayed cord clamping. WHO is saying delay means not before 1 minute. If you're going to delay not before 1 minute, you should clamp, but it can be anything between 1 to 3 minute delay. So delay means not before 1 minute. Do not clamp before 1 minute. Controlled contraction, image important. Controlled contraction is to be done only when trained birth attendants are available. Only when trained birth attendants are available. And intermittent uterine tone assessment is enough. Government of India says massage also, but please remember, when we have already given the uterotonics, doing the massage is okay. You do it. There's no harm in doing it, no harm in doing it, but you don't do it, it's fine. WHO says intermittent uterine tone assessment. There's only few valid indications of early cord clamping: when the newborn is asphyxiated, known heart disease of the baby, or increased maternal bleeding in the third stage, that we want to go for early cord clamping. Otherwise, please, preterm fetus, as long as the baby has come out crying, happy, moving, and blue and pink and everything, as long as it is a vigorous baby, it doesn't matter the gestational age, it doesn't matter the birth weight, preterm, term, whatever, as long as the baby is vigorous, it's delayed cord clamping. Rh negative mother, HIV positive mother, WHO says in all of these conditions it is delayed cord clamping that is more preferable, right? And that is what we are also doing in our situations. All right. So that is about the important pointers regarding AMTSL. Now coming to the next question. A G2P1L1 underwent LSCS. Bachche doctor, I've already told you uterine massage is included only according to Government of India. WHO is these 4 components in active management of third stage of labor. All right, early cord clamping is definitely not a part of active management of third stage of labor. Next, so if you have multiple options, you will have to look at the other options. Accordingly, you will have to answer. So LSCS, previous pregnancy for fetal distress. So she has a previous LSCS. And this time she had an uneventful vaginal birth after cesarean section. So she had a history of previous cesarean. Now she delivered vaginally. Placenta could not be removed completely. So you were giving traction. Cord snapped. Cord came, snapped, got avulsed. Placenta did not deliver. Retained. Started to bleed more profusely. What is the reason? Yes, very good. So previous cesarean is also a clue, right? The fact that placenta did not separate or separated in bits and pieces. Placenta did not separate at all. Placenta separate in bits and pieces. The other situation could be, let's say we were doing manual removal of placenta. We were doing manual removal of placenta. Plane of cleavage not found. These could be your clues. Then this is placenta accreta. This is placenta accreta. Okay. So placenta accreta is morbidly adherent placenta. These days we are seeing increasing number of placenta accreta cases because of rising number of previous cesarean cases. So please remember that more the number of previous cesarean cases, more is the risk of having a morbidly adherent placenta or placenta accreta. So please remember these image-based questions from placenta accreta which have been asked in the past, which have potential of being repeated. When you have placenta accreta is attached accreta just at the myometrium. See, this is the decidua basalis, this is normal, this is absent. Okay, the Nitabush layer is absent. Defective decidua basalis, this is the pathology in case of morbidly adherent placenta. So it can be attached to the myometrium, just attached at the myometrium. Increta, it is going into the myometrium deeper. Percreta, it has perforated the myometrium. It has perforated the myometrium, reached the serosa, or it has perforated the nearby tissues also, right? Tanya, delayed cord clamping is not 30 to 60 seconds. As per WHO, it is 1 to 3 minutes. It is when you call it delay when you have delayed it at least for 1 minute. Okay, at least for 1 minute delay you do, then there is some advantage. You delay it for less than that, there is no advantage. Then you might as well have done an early cord clamping. Okay, right. Now look at this. This is the image showing placenta accreta. Can you see this? This is a hysterectomy specimen. The placenta is still attached and it has not managed to separate. This is the patient that we were doing, and this is the, when we are doing a cesarean section for the patient, this is the placenta that has perforated all the way up to the serosa. So, this is a percreta case, placenta percreta case. Okay, so remember these important images for morbidly adherent placenta. Okay, now the investigation of choice for antenatal diagnosis. For antenatal diagnosis, please remember they will ask you this question, because the moment I have a situation, woman with previous cesarean section, plus she has placenta previa in this pregnancy, I am very suspicious of the possibility of morbidly adherent placenta. So, investigation of choice is going to be ultrasound Doppler to begin with. MRI for difficult cases, surgical planning, yes. But to begin with, initially, yes, initially ultrasound Doppler. Okay, now Irfan, TVS कैसे आएगा यहाँ पे? TVS, you may need to explore if it is the placenta previa and to see whether the placenta is coming near the edge of the cervical os or not. So, it is usually a combination of transabdominal and transvaginal scan. Understand, no, if you have to analyze anything closer to the cervix, it will be TVS. But if it's a big uterus, and then you have to see if it is going to be transabdominal depending upon how you get the imagery, right? So, it's ultrasound Doppler, TVS, transabdominal will depend. Now, look at these images also, right? So, this one here, image identification, yes, image identification, yes. This one here is an extra lobe and a leash of connecting vessels. This is succenturiate placenta. You may have a situation when there is an extra lobe and the extra lobe is almost equal in size to the main lobe, okay, main placenta. So, this is, and the umbilical cord could be attached in between the two lobes, or it could be attached to one part of the placenta. This is a bilobed placenta. This is a bilobed placenta. So, we are going quick with this, okay guys, because we will. Now, what is this image here? What is this one here? You can see a yellow rim, thick yellow rim of folded membranes, right? Thick yellow rim of folded membranes. This is circumvallate. Very good. This is circumvallate placenta. What is this? You can see the umbilical cord that is attached to the membranes. In the membranes, you can see naked fetal vessels. These are naked fetal vessels traveling in the membranes. Naked meaning they are not inside the umbilical cord. Inside the umbilical cord has got Wharton's jelly, which protects the, which is protective. It protects the umbilical vessels against compression. Okay, so here this is velamentous cord insertion. Here this is velamentous cord insertion. Here in this image on the left, velamentous cord insertion, succenturiate placenta also. Both situations could be associated with a situation when the fetal vessels come in front of the presenting part, then it becomes vasa previa. Then it is called as vasa previa. So, this portion, see these fetal vessels, naked fetal vessels, this portion coming in front of the presenting part. Naked fetal vessels coming in front of the presenting part, vasa previa. It will present with bleeding, but this bleeding will be fetal bleeding. This bleeding will be fetal bleeding. So, if vasa previa bleeds, which tends to happen when the membranes rupture or during labor, when the cervix opens up. This can be very life-threatening to the baby. All right. Now, next question. You are taking daily evening rounds, right? 23-year-old woman delivered her first child 2 days ago. So, this is postpartum day 2. She has bloody vaginal discharge. She is afebrile. Pulse rate is fine. Hemoglobin is fine. WBC count 10,000 is also fine. Some odor, bloody discharge, but sweetish odor. So, this is lochia. Her bloody discharge is also lochia. Uterus is well contracted just below the umbilicus. That's also fine. Non-tender, that's also fine. PV, os closed, vaginal fornices, non-tender, all okay. What is the most appropriate next step? Reassure. Very good. Reassure. Reassure would be the next step. Right? So, in her clinical profile, everything seems fine. Please remember the duration of lochia also. This is just postpartum day 2. Lochia initially will be rubra, red in color. What is the sequence of lochia? Rubra, serosa, alba. So, right now she is having lochia rubra, right? So, this is fine. The counts are also okay. Fever is also not there, right? The level of the uterus is also below the umbilicus. She is day 2. That's also fine. Right. So, there is no reason to go for any other management strategy right now, but just go for reassurance. All right. Please remember, when we say puerperium, the total duration is 6 weeks. And please remember, puerperium begins after placental delivery. Please remember, puerperium begins after placental delivery, and process by which the genital tract reverts back to non-pregnant state, that process is called as involution. They have asked you these questions, that where is the fundus immediately after delivery? It is just below the umbilicus. So, the level of the umbilicus is around 24 weeks. So, just below there it would be 22 weeks, around 22 weeks. So, that would be fine. And it weighs about 1000 grams. Right? After 24 hours, that is when the fundal height starts decreasing. For the initial 24 hours, it remains the same. Question: on the second postpartum day, it is 1 finger breadth below the umbilicus. 1 week postpartum, it is midway between the pubic symphysis and umbilicus. And uterus becomes a pelvic organ by 2 weeks, but yes, earliest by 10 to 12 days. But definitely so by 2 weeks. And it weighs about 100 grams on 4 weeks postpartum. And involution of the placental side takes complete 6 weeks, full 6 weeks it takes. So, these are some of the important pointers that you need to keep in mind. So, one-liner pointers. Next question. You are conducting the delivery of a multiparous woman. She is having gestational diabetes. Fetal weight 3.5. 3.5 by definition is not heavy baby. By definition is not macrosomia, right? But yes, is on the higher side, right? After delivery of the head, shoulders do not deliver spontaneously. Head recedes back onto perineum. What is this sign? This is turtle sign. Which maneuver will you do? Yes, Mac-Roberts maneuver. Very good. If they had mentioned suprapubic pressure, then also you would say Mac-Robert maneuver as the answer. This is better. This is the first maneuver that is attempted. Suprapubic pressure by assistant is often applied simultaneously, but the maneuver that you have to choose is Mac-Robert maneuver. That is the answer. See here in these images, this is the Mac-Robert maneuver. Right. So, flexing the thigh onto the maternal chest, flexing the thigh onto the abdomen and abducting. This is Mac-Robert maneuver. This is for shoulder dystocia. What is happening here? Shoulder dystocia. Right. Now, also remember that this is the first maneuver. All right. Suprapubic pressure by the assistant is often applied simultaneously. Fine. Right. And if the Mac-Robert maneuvers fail, then we go for other maneuvers, like if it fails, we can go for the internal rotational maneuvers also. Internal rotational maneuvers like Wood corkscrew maneuver, Rubin's maneuver. An obstetrician will do whichever maneuver he or she knows. Okay, but then you will have certain last resort maneuvers. Zavanelli maneuver is a last resort maneuver. Okay, so Zavanelli, fracturing the clavicle, cutting the pubic symphysis. If you hear about these things, you will realize that I've never done that. Okay, I've never seen that happen. So these are last resort maneuvers. Fortunately, so far in my life, I've never encountered these maneuvers being done. Right. So these are last resort maneuvers. All right. Now this is the Lofset's maneuver. Image-based identification. Lofsets, when you are in, I keep telling Lofsets, when you're in love with somebody, you extend your arms to hug that person. So extended arms. It's for breech delivery, in breech delivery, for extended arms. For breech delivery with extended arms, right? This is the Ridzen maneuver. When the head is at the perineum and the scalp is visible, right? For controlled delivery of the head. That is what the Ridzen maneuver is. Okay, so this is Ridzen maneuver, image-based identification, important. Again, these are image-based identifications for the maneuvers which are associated with breech. So, Morisot-Smellie, Burns-Marshall, as you can see, are for after coming head. Similarly, Piper's forceps is for after coming head of breech. These are specially designed for after coming head of breech. Prague is when the delivery of the head, when the back is posterior, dorso-posterior. All right. Now, Dushan's incision is done for after coming head when the head is stuck behind an incompletely dilated cervix. Groin traction, you can see fingers in the groin, so buttocks are being delivered. Pinards, P for Pinards, P for popliteal. It's a very famous mnemonic, everybody uses it. So, P for Pinard, P for popliteal, fingers in the popliteal fossa, it's for delivery of extended legs. Right. So, quickly recalled, these as images, image-based pointers can be asked, or match the column kind of questions can be asked, where you match the maneuver with where it is used. Next question. A pregnant woman at 26 weeks gestation underwent oral glucose tolerance test. For the FMGE, at least you should know that for India, for the Indian Government of India guidelines, we are having the DIPSI guidelines, right? So, you have to remember DIPSI guidelines, right? 75 gram oral glucose is used, all right? And irrespective of fasting, it is done. Okay, irrespective of fasting, it is done. Oh, excuse me. And 2 hours later, we check the blood sugar level. 140 milligram per deciliter is the cutoff, right? And this is for screening also, this is for diagnosis also. So, you see here, they are telling you fasting 130. By fasting 130, fasting more than 126, this is diabetes outside of pregnancy also. Not just in pregnancy, you don't have, the point is that now it has become easier to remember the values, because now WHO and everybody has standardized. Fasting more than 126 is overt range. 2 hour post glucose load 200 is in the overt range. It's already in the overt range. You do not repeat the test. You don't start insulin on OPD basis. Insulin has to be titrated. Right? So, you don't have to remember how insulin is titrated. You need to remember that pregnant women who have to be started on insulin should be started after admission. Admission, blood sugar monitoring, and start insulin. Insulin is the drug of choice. Please remember, for diabetes and pregnancy, insulin is the drug of choice. Okay? And blood sugar monitoring, we teach the woman how to do it self-monitoring at home. And repeating at 30 to 34 weeks now is not needed, because the diagnosis has been made. So, for now the answer is option number B. Okay. And also please remember that your diet therapy and exercise and all that is obviously going to be there also. Okay. So, if the blood sugars are in GDM range, right, GDM range. So these are overt range, fasting more than 126, 2-hour load more than 200, but these are overt range. This is overt range. Remember this. Your 2-hour cutoff was 140, right? GDM range, fasting between 92 to 126, right? 2-hour between 140 to 200, something like that. That's why I told you, remember what is overt range. Sugars in GDM range, we can start with what we call as medical nutrition therapy. Medical nutrition therapy. Lifestyle modification, diet therapy, exercise, all that, and then recheck the values after, do a sugar profile after 1 to 2 weeks, and then decide if insulin is required or not. But once the sugars are in overt range and not getting controlled, it is important that we start insulin. So the drug of choice is insulin. All right, clear? Now look at this question. A woman delivered twins by cesarean section. Identify the type of chorionicity from the image. Yes. What is the type of chorionicity? We know dichorionic, diamniotic, monochorionic, diamniotic, monochorionic. Oh, let me change this option. Misprint. Monochorionic, monoamniotic. And dichorionic monoamniotic, तो ये तो कुछ होता ही नहीं है. Yes, what is the answer? अरे dichorionic diamniotic, what are you saying? What are you saying? Are you not seeing properly? Look at this. Where is the intertwin membrane? There is no intertwin membrane here. And even if you are not able to see the intertwin membrane, can you see these cords entangled with each other? Which kind of twins will have these cord entanglement? Very specific cord entanglement. No separation in between the fetuses, no intertwin membrane, monochorionic, monoamniotic. What we are seeing here is cord entanglement. What we are seeing here is no intertwin membrane. This is cord entanglement, right? So this is very specific to monochorionic, monoamniotic. There can be these two twins could, because there is no intertwin membrane, there could be interlocking of fetal parts also. Cord entanglement like this, very high risk of dying. This is why monochorionic, monoamniotic twins are always delivered by cesarean section. Elective cesarean section between 32 to 34 weeks after giving them steroid cover for pulmonary maturity. This is one situation always elective cesarean. Right. Now look at these images and identify, right. So overall the most common type of twins are dizygotic twins and they are always dichorionic, diamniotic. Monozygotic twins, depending upon when they divide, will be when the division takes place within 3 days, dichorionic, diamniotic. This is dichorionic, diamniotic. Can you see? Intertwin membrane, thick intertwin membrane. In between there is a layer of chorion, right? So there is amnion, amnion, chorion in between. 4 layers, amnion, amnion, chorion, chorion. Right. So even though there could be 2 separate placentas, right, amnion, amnion, chorion in between, there could be 2 separate placentas or the placentas could be together very close to each other, but there is no sharing of placenta, right. So look at this, all right. We can check this on ultrasound also. Early pregnancy, very early pregnancy, we have 2 separate gestational sacs, sac 1, sac 2. Fetus 1, fetus 2, 2 separate gestational sac, dichorionic, diamniotic. The gestational sac is actually the chorionic cavity. Here what we are seeing? We are seeing twin 1, twin 2, right? This is the placenta. This is the intertwin membrane. You can see this dipping, chorion dipping. That's what I was trying to show you here. Chorion dipping, chorion dipping. This is the lambda sign. Twin peak sign, lambda sign, twin peak sign. What is this? Dichorionic, diamniotic. Where are we? Dichorionic, diamniotic. This is where we are. Okay, fine. So this is how you're going to quickly revise. Now, if the division takes place between 4 to 8 days, it is monochorionic, diamniotic. Where are we? Here, monochorionic, diamniotic. Here. See, Single placenta, fused, sharing of placenta. Look at the intertwin membrane. Right, look at the intertwin membrane, very thin, only amnion from both the twins. Right, look at this, no dipping of chorion in between, T sign. Look at this, twin 1, twin 2, placenta, T sign. This is monochorionic diamniotic, T sign, T sign. This is it, look at this placenta, single fused placenta, 2 cords from both the twins and very thin intertwin membrane, monochorionic diamniotic, okay. Now where are we? If the division takes place between 8 to 12 days of fertilization, this is monochorionic monoamniotic, this is where we are. No intertwin membrane, right, that is going to single fused placenta, sharing of placenta, no intertwin membrane, all right, fine. And if there is division beyond 12 days, it leads to conjoined twins, Siamese twin, conjoined twins. This one here, thoracopacus, right, this one here, joined at the thorax, they could be joined at various other places also. So, conjoined twins, all right. Now, please remember here that the best timing for chorionicity assessment is between 10 to 14 weeks of gestation. Must be done before 14. Must be done before 14 weeks. Between 10 to 14 weeks is chorionicity, and we do by ultrasound. How do we check? By ultrasound. Like I showed you the ultrasound images. Okay. Also remember that the mode of delivery in twins, they ask you questions on mode of delivery in twins, okay. So please remember, one, I have already told you, monochorionic monoamniotic. This is one situation, it is always elective cesarean. Otherwise, it doesn't matter dichorionic diamniotic or monochorionic diamniotic, the rest doesn't matter. Mode of delivery will be based on the first twin, presenting twin, that meaning the twin that is coming and entering in the presenting part, entering into the birth canal first, that is the first twin, presenting twin. As long as it is cephalic vertex, it is vaginal delivery. When it is anything other than vertex, other than cephalic, it is cesarean section. So, first twin cephalic, second twin cephalic, vaginal delivery. First twin cephalic, second breech, vaginal delivery. First cephalic, it's vaginal delivery. First one, presenting one, anything other than cephalic. First twin breech, first twin transverse lie, cesarean section, right? So, remember this. Next question. A G2P1L1 seen at 32, mild vaginal bleeding, she is stable right now, uterus relaxed, fetal heart rate is okay. Placenta in the lower segment within 2 cm of internal os. So, this is low lying. What is the next step in management? Yes, what is the next step in management? बताया तो डॉक्टर वीके, वर्टेक्स, फर्स्ट ट्विन वर्टेक्स, सेकेंड ट्विन वर्टेक्स, वेजाइनल. फर्स्ट को देखो, सेकंड को देखो भी मत, ओके. फर्स्ट वर्टेक्स वेजाइनल and first anything other than vertex or cephalic where vaginal delivery is not possible, first breech, first transverse lie, it is cesarean section, okay. An internal podalic version for delivery of second twin in transverse lie. This is the only indication for internal podalic version in entire obstetrics, period. Coming back to the question here, what do we do? What is the next step in management? मैंने क्या उल्टा बोल दिया? अब तो सुल्टा कर दिया होगा मैंने, हैं? First twin cephalic vaginal delivery, first twin anything other than cephalic, other than vertex, cesarean section. Clear? Okay. What is the next step in management? Okay, so I am getting A, I am also getting D. See, this is low-lying placenta, all right. So, if she had never bled, okay, for a low-lying placenta or placenta previa, this one here is low-lying placenta. If she has never ever bled, then we schedule elective at 37 completed weeks. Okay, that is correct. And right now she is already bleeding, but she is having mild bleeding. Most of the times the first episode is warning hemorrhage. She is preterm, she is not in labor, right? She is not in labor. If she is already reached 37 weeks, more than equal to 37, so term basically. If she is already in labor, or she is unstable, or the bleeding PV continues, or there is fetal distress and it's a viable fetus. Fetus can be saved, viable fetus, fetal distress. Then we go for emergency LSCS. Okay. Right now, she is 32. First of all, you will admit her. All these APH patients need to be admitted. Nothing can be done on an OPD basis. Right. For now, conservative management and start steroids. Because baby is fine, bleeding is mild, uterus is relaxed, she is not in labor, she is preterm, right? We can still watch. That is why I said admit, arrange for blood, resuscitate, everything has to be there. So, right now conservative and start steroids. There is obviously no vaginal delivery possible. Right now we don't do a cesarean section. We can still maybe buy enough time to complete the steroid cover. At least that much we are going to do. Right? Isn't it? So, at least that much we are going to do. Right? Yes, of course, I have admitted, I am watching for complications, I am watching the bleeding, I am monitoring the patients, I am checking her pulse rate, checking her bleeding, keeping blood arranged, everything I am doing. I have started the steroids. So, I am doing this conservative management, but in case she starts having pain, she starts going into labor, bleeding continues, something fetal distress sets in or whatever, I can stop the conservative management and go for an emergency cesarean section. But for now, conservative management and start steroids. Right? If she had never bled, yes, we would have, maybe scheduled an elective cesarean section at 37 weeks, right? And the session is going to continue for another half hour. Session is going to continue for another half hour. Okay? Now, if bleeding continues, tocolytic, no, bacha, see, for placental abruption, for previa cases, undergraduate students don't learn tocolytic. Tocolysis in exceptional circumstances. Those exceptional circumstances, I don't think even they're even very rare for postgraduate students. So, at the undergraduate level, please remember, for antepartum hemorrhage, whether it is placenta previa, whether it is placental abruption, tocolysis is not a priority, never a priority, right? It is delivery. Keep that in mind. Okay. Next question. A young woman is diagnosed with following uterine anomaly. Acha, following uterine anomaly. Wait, forget it. The image is not there. Let us just see these. Let us see these images. Let us see these images. Let us see these images. Let us see these important images. Again, these are previous year topics, previous year questions. So, these are uterine anomalies. They are arising from Mullerian duct anomalies, Mullerian duct, paramesonephric duct. Right? So, these are Mullerian anomalies arising because of development disorders in the paramesonephric duct. You can see here that these are again the uterus and the fallopian tubes and the cervix and the upper part of vagina, they arise from the Mullerian duct. So you can see here that these two Mullerian ducts are partially fused. Okay, they are partially fused. So this is bicornuate uterus. Please see the HSG image also. There is a dip at the fundus here. That is why it is bicornuate uterus. If you see the HSG image, look at the angle. Angle, if it is obtuse, it is most likely bicornuate. Right? Image on the left. Second image. This is most likely septate uterus. This is most likely septate uterus. Look at the fundus intact. So problem is not with the fusion. Fundus is intact. The problem is not with the fusion of the Mullerian ducts. There is failure of dissolution of the septum. Okay, there is failure or incomplete dissolution of septum. Then this is septate uterus. So angle acute. This is didelphys uterus. Right? There is complete failure of fusion. So please remember here there are two separate cervix. Okay, they will be mentioned two separate cervix. Here we can see two cavities and two cannulas. Something of that clue would be there. Two cervix will be mentioned, two separate cervix will be mentioned. Please remember that. Please see if it is an HSG film, there will be two cannulas. Okay. And this one here is unicornuate. Where only one side paramesonephric duct is developing, the other side is not developing. Right? The most common presentation with these Mullerian anomalies is second trimester pregnancy losses. This is the most common presentation. Okay? And this is also the most common indication for a surgery. Right? So, please remember here that incidental diagnosis surgery is not done. This is also the most common indication for surgical repair. When there are second trimester pregnancy losses, there can be recurrent second trimester pregnancy losses. And please remember for septate uterus, particularly for septate uterus, they have asked this question and they are going to ask you about septate uterus because this is the one that is most commonly identified. Hysteroscopic septum resection will be done. Okay, that is going to be done. And if there is, let's say for example, infertility with septate uterus, right, recurrent pregnancy loss with septate uterus, something like this. So clinical context could be recurrent pregnancy loss with septate uterus, infertility with septate uterus. Answer is hysteroscopic septum resection. Okay. Next question. A woman is seen in emergency in collapse state, home delivery, tachy, hypotension, shock out of proportion to bleeding, boggy reddish mass out of the introitus, direct image based question, biggest clue, fundus not palpable perabdominally. So this is it, this is the inverted lining. See, this is the inverted lining of the uterus. This, I'll just mark it with another outline. This is the inverted lining, the decidua, the red boggish mass, the red boggish lining, decidual lining, that is obvious, right? We are not seeing any cervix anywhere, okay? Prolapse image we saw earlier. At that time I told you I'll show you uterus inversion image separately. So this is not uterine prolapse, right? Obviously, if the uterus has inverted, fundus has inverted, then it will not be palpable perabdominally. So this is uterine inversion. Okay, this is not retained placenta, this is not DIC, right? Please remember that initially the shock is out of proportion to visible bleeding because initially there is neurogenic shock. So women complains, sharp pain, abdomen, neurogenic element to the shock and also bradycardia and hypotension may be there. Later, yes, there will be hemorrhagic shock. I'm just writing H shock, hemorrhagic shock, later hemorrhagic shock, and this is the cause of death. Most women will not die of the neurogenic shock, they'll recover from the neurogenic component, but unattended, yes, later hemorrhagic shock will be the cause of death, right? What will be the management? The management will be repositioning. Management will be repositioning. Manual repositioning will be done, that is Johnson's method. Manual reposition, that is Johnson's method. Please remember, ideally this method, see, as far as undergraduate students are concerned, what we expect you to know is that you are able to identify the situation, you are able to call for help, you are able to understand that you need to inform the senior person, because ideally this will be done in the OT. So you need to inform the OT person also. So this is how you are going to remember. So ideally this manual repositioning should be done in the OT by experienced person, by the senior person, all right, under antibiotic cover. So if you're going to take into OT, push it inside and everything, so under antibiotic cover, under appropriate anesthesia, ideally, okay, mark my word, ideally. And the other important thing that you need to remember as far as undergraduate students, here in this image the placenta is not attached. I keep telling you there can be a situation where it is a morbidly adherent placenta and we were pulling at it and we caused inversion of the uterus, because the most common reason for uterine inversion during labor happening, during delivery happening, is mismanagement of third stage of labor. Something gone wrong. We were pulling when the uterus was relaxed, we were pulling with too much force, it was a morbidly adherent placenta, we didn't know, we were pulling too hard and we inverted the uterus. So if the placenta is still attached, do not attempt to separate the placenta, because it could be a morbidly adherent placenta. The more we try to separate it in bits and pieces, the more it bleeds. So if the placenta is still attached, then we reposition with placenta in situ, right? So please remember, management will be repositioning. So I've been very fast with this, but this is what you need to remember, the key important pointers, that you need to call for help, you need to identify if there is a placenta still attached. Do not attempt to remove the placenta by yourself. Okay, so this is important, keep that in mind. So we first reposition it and then remove it, and then the removal part will be done by the senior person. Okay. Now, antenatal assessment, antenatal Doppler assessment of which of the following vessel is used for early detection of fetal anemia? Yes, early detection of fetal anemia, yes. Which, when there is fetal anemia, blood flows faster and reaches the brain, because baby decides that I am having anemia, baby decides that I want to give more blood to my very vital organ, that is the brain. Okay. So middle cerebral artery blood flow, we check the peak systolic velocity of the middle cerebral artery, right, and that is used for early detection of fetal anemia. Umbilical artery Doppler is for evaluation of fetal growth restricted fetuses. That is where umbilical artery Doppler is used. And yes, 1.5 multiple of median is the cutoff for early detection of fetal anemia. Ductus venosus will show terminal changes in fetal growth restriction. I mean, just when the fetus is about to die, let's say in utero, then terminal changes come in ductus venosus Doppler. So ideally, yes, for fetal growth restriction fetuses, if we want to evaluate, you go for umbilical artery Doppler first, priority umbilical artery Doppler. Okay. Uterine artery Doppler, where is it used? Now we will also complete uterine artery Doppler. Where is uterine artery Doppler used? Yes, uterine artery Doppler is predictive of, see, so basically just remember where is it used. Okay. So it is predictive for fetal growth restriction, because uteroplacental insufficiency, right? So for uteroplacental insufficiency, placenta is being supplied by the uterine artery. So blood flows in the uterine artery can be assessed for prediction of fetal growth restriction. I am not going into too much details. For prediction of fetal growth restriction more than preeclampsia, okay, more than preeclampsia. So these are the two situations where uterine artery Doppler in obstetrics has utility. Okay, so remember these pointers where these Dopplers are used in obstetrics, right? Now, next question. 19-year-old primey seen at 33 weeks complained of labor pain. She is getting 3 contractions in 10 minutes. Cervix is 2 centimeters dilated. She is in preterm labor. She is in preterm labor. Which drug is given for promoting pulmonary maturity in the fetus? This question and pertaining to these questions have been asked again and again in your exams. First, you need to identify that she is in preterm labor. She is less than 34 weeks, right? Less than 34 weeks is what we call as early preterm. Less than 34 we call as early preterm, and 34 to 37 weeks we call as late preterm, right? Less than 34 weeks is very, very important because pulmonary maturity is not there, right? So we have to give corticosteroids in this situation, right? We have to give corticosteroids in this situation for pulmonary maturity, right? And the only indication for tocolysis, would be if we want to buy time for steroids. When we want to buy time for steroids, because steroids will take 48 hours, right? So the drug of choice here for us is Dexa. It is 6 milligram IM 12 hourly for 4 dosages, right? So it will take a full 48 hours for the steroid cover to get completed, right? So the two valid indications of tocolysis are that we want to buy time for steroids to cover the steroid cover, or when we are referring the patient to a higher center, right? So for example, this particular patient, because she is getting contractions also, cervix is also opening up, in addition to corticosteroids, she will also need tocolysis. But in this question, they are only asking about pulmonary maturity, so the answer is corticosteroids. Progesterone is not a tocolytic. Progesterone treatment is not a tocolytic. It is for prevention of preterm birth. Prevention of preterm birth when the woman is not in labor, okay? Please, not for established preterm labor. It's not a tocolytic. It is for prevention of preterm birth in women who are at high risk of preterm birth. That's all. Indomethacin, magnesium sulfate, both have tocolytic actions. Magnesium sulfate in clinical practice as a tocolytic agent, we are not using that often. Indomethacin, yes, please remember, indomethacin is not to be used beyond 32 weeks, not to be used beyond 32 weeks as tocolytic, because it causes premature closure of ductus arteriosus. That is why it is not to be used as a tocolytic beyond 32 weeks. For us in our setups, generally our drug of choice for tocolytic is nifedipine, generally nifedipine. Okay, that is in general our tocolytic of choice. Okay, keep that in mind also. And there is a very, very important indication of magnesium sulfate. Magnesium sulfate in preterm labor with imminent delivery. Why is it used? Not as a tocolytic. In extreme preterm, less than 30 to 32 weeks. What is the reason? For fetal neuroprotection, corticosteroid given to mother or baby. By you tell me, fetus is still inside, how will you give it to the fetus? You want it to reach the fetus? Yes, of course. You want it to reach the fetus, but you will give it to the mother, okay? Via placenta, it will reach the fetus. That is why it has to be either dexamethasone or betamethasone, not any other steroid, because these are the type of steroids that will be able to cross the placenta and not be metabolized by the placenta. All right. So magnesium sulfate again for fetal neuroprotection, for prevention of, let's say, cerebral palsy. And another place where whatever you are mentioning, prevention of seizures and urine output, whatever you are mentioning, has a role in here. This question, let's look at this question. 21-year-old primey seen in OPD for the first time, 8-month pregnancy, pedal edema, extending up to knees, facial puffiness, blood pressure 150/100, uterus corresponds to 32 week size, so she's 8 month, 32 weeks, fetal heart rate fine, dipstick +2 protein. All of the following are done except, so this would be the last question, this would be the last question. All of the following are done except, yes, hypertensive disorders, very, very important, excellent. All of the following are done except immediate induction of labor. So all hypertensive patients ideally should be admitted and worked up. Okay, so don't send, undergraduate students should not send hypertensive patients away from the OPD. You admit, yes. Okay, proteinuria is there. Proteinuria can be checked by dipstick. Proteinuria can be checked by urine protein creatinine ratio or 24-hour urine protein, whatever method. One very easy way to do is in the OPD, urine protein by dipstick. So proteinuria is there, but we also need to look for the end organ changes. What are the end organ changes? What are the organ changes? You send the CBC. In CBC, we can look at evidence of hemolysis. In CBC, you will look at evidence of hemolysis, peripheral smear. Okay, you can look at thrombocytopenia. Right. In LFT, what do you want to see? In LFT, what do you want to see? You want to see the liver enzymes, elevated AST and ALT. Right. In KFT, what do you want to see? In KFT, you want to see the creatinine. So, serum creatinine more than 1.1 milligram per deciliter. That is important. So, that is this. And cerebral symptoms, broadly cerebral symptoms. Right. So, what do you see in cerebral symptoms? What do you see? You ask, you send the CBC, LFT, KFT, you always ask about what? Headache, blurring of vision, epigastric pain or right upper quadrant pain, meaning liver involvement is extensive. Okay. You always ask about any difficulty breathing because pulmonary edema again is an end organ change. Please remember that these, specifically these three, headache, epigastric vision, blurring of vision, epigastric pain, epigastric pain, headache, blurring of vision. Signs and symptoms of impending eclampsia. Eclampsia is a patient with preeclampsia complicated by convulsions. Impending eclampsia meaning if these signs and symptoms are there, she may end up having a convulsion any time now. That's why all these patients, you need to look for end organ changes, because if the BP is more than 160/110 persistently and or there is any end organ change, you will say it is severe preeclampsia. It is severe preeclampsia. Persistently BP more than 160/110 and or any end organ change. Degree of proteinuria I am not mentioning, I am not saying. Degree of proteinuria is not related to severity. Right. So, keep this in mind, right. This is broadly you have to understand. So, you have to, right now she is preterm, right now she is 32 weeks. So, you have to start the antihypertensives to control the blood pressure, yes, right. So, the drug of choice for BP control is labetalol. Drug of choice for antihypertensive is labetalol, right. Keep that in mind. And whether it is oral labetalol or when we want to give for acute hypertensive crisis, we can give IV labetalol. It's labetalol. Okay. Nifedipine is also first line. Nifedipine is also first line. So, in a situation where labetalol for medical reasons, like for example, bradycardia or bronchial asthma, well, labetalol is contraindicated, nifedipine can be used, right. So, nifedipine is also first line, at least remember this much, right. So, you will start antihypertensives, yes. You have admitted, yes. Okay. On admission, you send the investigations, you asked for the danger signs. And when we have kept admitted in the ward, we are following that same protocol. We are evaluating the mother, looking for danger sign, repeating the investigations as and when needed, and taking care of fetal well-being, also evaluating for fetal well-being also, because there are two people involved here, mother and baby. All right. So what is the gist? Okay, what is the gist? I will just write the gist maybe here. Final gist of the day. Final gist of the day is that when you have a situation of preeclampsia, the whole thing is that you have to deliver, because that is the ultimate treatment. That is the definitive treatment. Question is when. So we have admitted, we are monitoring, checking mother status, checking fetal status every now and then repeatedly, right? As long as it is mild preeclampsia, we can, and BP is under control, mother, baby, well, we can plan induction of labor at 37 completed weeks. Cesarean section is for obstetric indication, period. If it is severe preeclampsia and she is already more than 34 weeks, deliver. If she is severe preeclampsia less than 34 weeks, start with conservative management. Start with conservative management. What is conservative management? BP control. Watch for signs and symptoms, watch for danger signs and symptoms, right? At least that. Keep that in mind, okay? And monitor mother and baby, right? Now, there will be certain situations where you will deliver irrespective of POG. There will be certain conditions where you will deliver irrespective of POG. That means that whenever she presented, or you may have admitted, started with conservative management, but now this is happening, then you deliver irrespective of POG. What is that irrespective of POG? Eclampsia, if she is having convulsions, if she is having signs and symptoms of impending eclampsia, deliver. Placental abruption happening, deliver. HELP syndrome happening, deliver. HELP syndrome happening, deliver. Right? So, you keep these important pointers in mind. Obviously, if fetal distress is happening, then also you deliver. All right. And what is HELP syndrome? HELP syndrome is hemolysis, elevated liver enzymes, low platelets. Then also you deliver irrespective of POG. Okay. And when you are delivering a case of, I'll just make another thing. You are delivering a case of severe preeclampsia. You are delivering a case of irrespective of POG. You are delivering a woman in any of these situations with preeclampsia. Okay, with preeclampsia, please remember magnesium sulfate, prophylactic magnesium sulfate. Prophylactic magnesium sulfate needs to be given. Okay, for prevention of convulsions, right? So, magnesium sulfate here becomes important. Okay, so when you have a patient with eclampsia, priority is to give magnesium sulfate here. When you have signs and symptoms of impending eclampsia, magnesium sulfate here. When you have HELP syndrome, give magnesium sulfate. The ones that I am ticking, please need magnesium sulfate infusion. Eclampsia, give magnesium sulfate, it will prevent further convulsions. Signs and symptoms of impending eclampsia, give magnesium sulfate, it will prevent convulsions from happening, prevent neuroprotection to the mother. HELP syndrome, again, give prophylactic magnesium sulfate. At least remember this much. And yes, you need to know the dosage also. Yes, Irfan, you are right. 4 gram IV and 10 grams IM. That is in the Pritchard regime, it is a total dose of 14 grams as far as the Pritchard regime is concerned. Okay. All right, keep that in mind also. And as far as magnesium sulfate is concerned, what are you monitoring? While on magnesium sulfate, you are monitoring knee jerk, respiratory rate and urine output. Okay, loss of knee jerk is the first thing to go when there is magnesium sulfate. Knee jerk should be present. Respiratory rate should be more than 14 per minute. Urine output should be more than 100 ml per 4 hours. Right? So, I have written in that order. Okay, knee jerk should be present. Knee jerk is the loss of knee jerk is the first sign of toxicity. Okay, then comes respiratory depression, then comes cardiac arrest. Okay, and magnesium sulfate is excreted renally. Okay, so that is why urine output is measured, not because magnesium sulfate causes decreased urine output, but in women with preeclampsia or eclampsia, there can be renal involvement and there can be oliguria because of that. And if oliguria happens, if urine output is not maintained, then patients can develop magnesium sulfate toxicity. And yes, 100 ml per 4 hours or 30 ml per hour would be the same thing, right? So with this, we finish off the session. We wrap up the session. I have another session planned for you people where we are going to discuss the gynae cancers. In short, in brief, particularly focus for your FMGE exam, all right? And that session will happen on 23rd of this month. 23rd of December is when it is scheduled, because one thing that is missing from today's discussion, which we did not touch upon, is gynae cancers, all right? So for those of you who have still any more doubt left, any more questions you want discussed, you come with your doubts on 23rd. We will take up those doubts there, all right? So with this, we wrap up the session for today. Please, I am also highlighting that the questions that I have discussed, it is from these areas, these topics that you need to put most focus on. All right, hardcore obstetric topics, labor room topics, delivery topics, twins, hypertension, preeclampsia, eclampsia, these are your most important topics. Gynae, they ask more often these days. I've seen gynae, they ask more often. Again, infertility workup, abnormal uterine bleeding, postmenopausal bleeding, amenorrheas. These are the areas they ask you question from most of the times. All right. So this is what you should focus most often. All right. And all right, for the questions left in the PDF, I'll mark the correct answers, and if there is any extra information, I will write it there. I'll do that much for you guys. Okay? Chalo, take care. Thank you so much. We'll end the session for today.